Good morning, everyone, and welcome to the Save My Heart webinar, Out of Hospital Cardiac Arrest and the Impact of COVID-19 Experiences and Insights. We're going to give all the attendees a minute to join, and then we'll start the program. All right, it's 9:21. We're going to go ahead and get started. Again, I would like to welcome everyone to the Save My Heart webinar, Out of Hospital Cardiac Arrest and the Impact of COVID-19 Experiences and Insights. My name is Jim Pribble, and I'll be the moderator for today's webinar. The Save My Heart Committee has put together a terrific lineup for today's webinar. We have expert speakers from around the US and globe to discuss some of the lessons learned during the COVID pandemic and to guide us towards important next steps to improving out-of-hospital cardiac arrest survival in the COVID era. We hope you'll be with us for the entire webinar. Before we begin the program, I would like to briefly provide some quick notes on the meeting format. The agenda will move along in 30-minute blocks. Each speaker will be provided around 25 minutes for their presentation. This will allow for 5 minutes for questions and answers following each talk. We wanted to make this webinar open to anyone and with very few barriers to join. Therefore, we are not able to provide CME for this webinar. The webinar will be recorded, and your participation is your consent. This recording will be available on our Save My Heart website soon after the completion of the webinar. And in order to better understand and engage our audience, we have developed a few polling questions for the attendees. So please respond to these polling questions, and these answers are all kept anonymous, so feel free to respond. And with that said, I would like to open up our first polling question. So please respond by telling us your profession. We have about 80% participation so far, so we're almost there. All right, and I'm gonna go ahead and end the poll now, and I'll share those results. In order to optimally manage today's webinar, the chat, audio, and video functions have been disabled for the attendees. The attendees' participation is critical, however, and your participation will be mainly through answering the polls and by asking questions through the Q&A function. The QA board will be monitored by the Save My Heart staff. The staff will focus on prominent questions, major themes, and questions that have been upvoted by the attendees. So if you see a question that has been asked that you feel is important, please vote for this question in the QA board. The selected questions will be asked to the speaker by the moderator during the 5-minute Q&A sections at the end of each presentation. Finally, as we need time to identify prominent questions from the QA board, please post your questions during the presentation and don't wait until the end of the talk to post your questions. In order to stay on time, we may not be able to get to all questions during the 5-minute Q&A. However, any prominent questions not answered during the webinar will be answered and posted to our website as soon as possible after the conference. The final selection today will consist of a panel discussions at the end. And finally, before we get to our first speaker, I wanted to inform everyone that once the webinar is over, you should receive a post-webinar survey that should open up in a new tab at the end of the webinar today. We would really appreciate everyone taking the time to complete this. So before I introduce our first speaker, I would like to launch our second poll question. What link in the chain of survival do you feel has been most affected by COVID-19? And we're about 80%. I'll give a few more seconds here to finish up. Okay, and I'll share those results. So moving on to the first presentation, I'd like to just make an announcement that in order to understand how to progress in the COVID era, we need to first understand where we are currently. So specifically, this talk will really focus a lot on the Michigan 2019 CARES data, so we can understand where we are and what progress we need to make going forward. And so I'd like to introduce our first speaker, Dr. Robert Newmar. Dr. Newmar is the professor and chair of emergency medicine at the University of Michigan. He'll be providing us with a Michigan CARES out-of-hospital cardiac arrest data update. Dr. Newmar, you can go ahead and start sharing your slides.
Okay, how does that look? Okay, and my sound is good? All right, well, thank you, Jim, for that introduction, and appreciate the opportunity to talk about our Save My Heart program and what progress we've made to date, including our updated data from 2019, and then talk a little bit about and what's the potential and expected impact of the COVID-19 pandemic as we move forward in the year to come in our efforts to continue to improve cardiac arrest outcomes in the state of Michigan. So make sure that I can advance. All right, so I'm not able to advance. Oh, there we go. These are my disclosures. Currently co-chair of the International Liaison Committee on Resuscitation, serving now as president and board chair of Save My Heart. Have had previous roles in the American Heart Association. Some of my research funding is NIH and AHA, and I do get some equipment support from Physio-Control for research. So for those of you that aren't familiar with the Save My Heart program, this is really a collaboration between within the state of Michigan, between EMS transporting agencies, first responding agencies, hospital systems, and academic medical centers that have come together with the goal set back about 5 or 6 years ago of doubling cardiac arrest survival in Michigan by 2020. And this was aligned with the American Heart Association goals of doubling cardiac arrest survival nationwide in the same time frame. And if we achieve that goal, just to remind everyone what that means, if we were to achieve the goal of doubling cardiac arrest survival in our state, that would save one extra life every day. And we recognize when we develop this program that it really requires a comprehensive look at the entire system of care, because we know that we're only as strong as our weakest link. So our programs look at bystander response, 911 dispatch, EMS system performance, and hospital care, all of which are key to optimizing outcomes for out-of-hospital cardiac arrest. And fundamentally, if you can't measure it, you can't improve it. So as part of our initial infrastructure building, we partnered with the National CARES Registry to create a statewide registry. for our cardiac arrest process measures and outcomes. And that really is the foundation of the work that we're doing in terms of understanding where we are in order to figure out the best ways to improve. And I just want to call out and acknowledge the work of Terry Shields, our state coordinator, who's done a tremendous job in building the infrastructure for our statewide CARES network over the past 6 years. And I'm just going to show you some of the statistics of our network here in the state. So we have included now 151 EMS agencies are reporting data to the CARES network, to the registry. 116 hospitals are participating. And if you look at the population of Michigan of 9.9 million, our coverage for the CARES registry is 9.2 million lives, which means that 93% of the population of the state of Michigan is covered in the registry and the data that we're collecting. So it's just really a phenomenal job that Terry has done in engaging statewide participation in this really critical registry in order to improve cardiac arrest outcomes. So with those numbers in 2019, we collected data on 7,727 cardiac arrests. That gives us a treated incidence of 84 per 100,000, which actually is a relatively high number if you look at some of the other numbers across the country. And then just getting to our data, and I'm going to orient you to all these data slides. What we've been doing since 2014 is following our progress on key performance and outcome measures and comparing that nationally. So the national data is in black, the Michigan data is in red, and then our strategic goal for each one of these is highlighted as a star on the right there under 2020 of what we felt we needed to get to in order to achieve our doubling of cardiac arrest survival. So as you can see, our bystander CPR rate has actually improved continuously since the beginning of our initiatives. And really for the first time, we've gone from below the national average to a little bit above the national average in 2019, which is encouraging and reflects a lot of the efforts we've done to try to improve bystander CPR rates statewide. More dramatic has been our bystander AED applied rate. And again, this is the way we report this is a little bit different from the way the CARES registry reports this. We report this as proportion of all treated cardiac arrests that had a bystander apply an AED. And you can see we are significantly above the national average in that and have had really dramatic growth in that over the past 2 years, where almost 10% of the treated cardiac arrests had a bystander apply an AED in 2019. Our ROSC rate, again, relative to national averages, this year we we started back in 2014 fairly well below the national ROSC rate in the CARES registry, and this year we've achieved sort of equity with the national ROSC rate, right around 30%, which again is a significant improvement from our baseline of 26%. And then our survival rate changes have been less dramatic. So if you can see, this is survival to hospital discharge. Again, national in black, trends over time, Michigan in red. And then you can see we started at a survival to hospital discharge rate of 7.9% in 2014, and we're up to 8.7%. Our goal, our ultimate goal in doubling survival was to get to 15.8%, which is the green star on the right. And then importantly, it's not just survival, but it's survival with good neurologic outcome. That's critically important. And again, improvement over time since 2014 from our baseline in the red graph there of 6.2 up to 7.1%, but still below national averages and distant from our 2020 goal in terms of survival with good neurologic outcome. And then hospital mortality rate, this is basically, just to orient you, this is calculated as of the patients that survive long enough to get admitted to the hospital, what proportion of those patients die in the hospital. And this really, we look at this as a reflection of the quality of the in-hospital care for the patients that are delivered from the EMS systems. And you can see at baseline, our hospital mortality rate was slightly higher than the national average. And this is one area we really haven't made progress in the past 5 years in improving our hospital mortality rate. It really is stuck at 66%, or 2/3 of the patients admitted to the hospital after an out-of-hospital cardiac arrest are die before they leave the hospital, and our goal was to get that down to 55%. So if you put that all together in terms of survival curve, this is sort of a way of looking at our progress across the system of care. And the parameters there are return of spontaneous circulation, survival to admission, survival to discharge of the hospital, and then the CPC 1 or 2 is a good neurologic outcome. And the black is where we started in 2014. The red is where we are in 2019, and the green was our ambitious 2020 goal that we thought would be required to double survival. And this reflects, basically where we've made most of our progress is on the EMS side of improving the care parameters, and that has not been quite as well translated into the ultimate outcomes. So another way of looking at this is our dashboard. So again, those similar parameters of process variables and outcomes. We have here on the first column is our baseline. Second column is our current status, is our goal, is the third column. And if we look at sort of our status, for the majority of our parameters, we're sort of, I would call in the yellow, where we're making progress, but not as rapidly as we would want for our 2020 goal. With the exception, I think, of the bystander AED application, where those programs seem to be very successful. And although we're not at our goal, we have a pretty good trajectory. And then I would give a red status for our in-hospital mortality, where we really aren't making progress to get down to that 55%. Now, these are statistics, and in some ways, not as impressive as we want to do in terms of improving outcomes. But I'll tell you, we are making progress in the work that the EMS systems, the first responders, the hospital systems are doing. Really is having an impact. So if you look at it in terms of survivors, in 2019, there were 549 survivors with good neurologic outcome in the state of Michigan. So that's 549 people that would not be alive and back to their good function if it weren't for the entire system of care for out-of-hospital cardiac arrest. And that's really important, and that's what's most important to all of us. And in addition, compared to last year, we saved 33 more lives than in 2018. So again, modest progress, but we are making progress, and each one of those lives is important and critical, and demonstrates the impact of the programs that we're doing to improve outcomes. So another way to look at this, though, in terms of looking forward, is how variable the different process variables and outcomes are across the state. And the reason it's important to look at variability is it demonstrates what is feasible and the opportunity for improvement. So the data I presented in the previous graphs really was averages across the state of Michigan. The data I'm going to present here is based on anonymized individual data from either EMS agencies or individual hospitals. And if you look at the overall survival rate in the state of Michigan, you can see that the range of survival rate is from 2% to 22%. So that's an order of magnitude difference in terms of your survival to hospital discharge basically based on where you have your out-of-hospital cardiac arrest. As you can see here, the national average is a little bit over 10. We were around 8 on our average, and our goal was to get to 15.8%. But what I want to highlight here is there's 4 systems in the state that have a out-of-hospital cardiac arrest survival rate of 15.8% or better, which at least indicates that it's possible to get to our very ambitious goals that we've set statewide. So again, huge variability across our system, which I look at as an opportunity to take best practices in our best systems and try to learn from that. So I'm going to break this down into some process variables about pre-hospital and hospital variability. So in terms of pre-hospital variability, this is our range of bystander CPR rates. So again, EMS agencies that transport at least 20 non-traumatic cardiac arrests in 2019, And you can see our range of bystander CPR goes from 4% to 73%. Again, more than an order of magnitude difference in bystander CPR rates, and illustrating that there's 7 EMS systems in which the bystander CPR rate is at our goal of 55%. Further demonstrating that it is feasible to get to the goals that we've set, and we can learn from the systems where that has been achieved. Similarly, there's significant variability of an order of magnitude in OHCA rates, again, in systems that have at least 50 non-traumatic cardiac arrests a year. And you can see ranging from 5% to 49%. The national average there is at 30%, so we're right around that in the state on average, with a goal of 37%. At least 8 systems in the state have been able to achieve that Save My Heart target. I apologize for the background sound. I think there's a fire alarm test going on, so hopefully that won't be too distracting. And then in terms of hospital variability, so that, that demonstrates that there's huge variability in our EMS systems and a real opportunity there for optimization. And I think similarly, we see that in the hospital. This is the rates of coronary angiography in individual hospitals in the state of Michigan, where they had at least 5 admitted post-cardiac arrest patients in 2019. And as you can see, the range of coronary angiography, that's taking people to the cath lab post-arrest to address acute coronary occlusion if present, ranges from 0% in many hospitals all the way up to 50%. Even more dramatic is the use of therapeutic hypothermia in the hospital. And again, it just to remind people, this is a level 1 recommendation from ILCOR and the American Heart Association to treat comatose cardiac arrest survivors with therapeutic hypothermia. The national average is about 47%, and our range goes from 0% to 75%, which is a huge disparity in that particular therapy that most of the evidence suggests is beneficial in terms of proving outcomes. And then if you look at just the outcome of in-hospital mortality, again, our Save My Heart goal was to get to below 55%. Our average is at about 66%, but the range, again, demonstrates significant variability all the way from as low as 34% up to 100%, with 15 hospitals achieving that goal of a in-hospital mortality rate less than 55%, further demonstrating the feasibility. So what do we do about that? So one of the things that these data demonstrate is that there are both EMS systems and hospitals within the state of Michigan that have had good outcomes. Now, some of that could be related to issues that aren't adjustable by the system in terms of patient populations or other infrastructure issues. But one of the programs that has been funded by the NIH that's led by Mashida Beer and Brahmaji Nalamathu that we're doing statewide is the EPOC program, where we're looking to enhance pre-hospital outcomes for cardiac arrest by trying to identify best practices. And some of you on the call have been involved in this. The work has been to identify best practices in the systems that have the highest survival rates and outcomes, and also identify the barriers and challenges that might exist in systems that have the lower outcomes. And using that, the EPOC team has generated a group of best practices and barriers that they're going to try to move forward into creating an EPOC toolkit that EMS systems can deploy across the state. So I just wanted to give you a heads up that actually coming soon to an EMS agency near you will be aim 3 of this study, where there's going to be a survey to validate best practices for out-of-hospital cardiac arrest, known as the EPOC toolkit. And that survey will survey EMS agencies for the presence of those facilitators and barriers to optimal out-of-cardiac arrest care. And we're going to try to survey 430 EMS agencies. And then they're going to be correlated with the CARES data in the participating agencies to try to correlate those best practices with outcomes to validate what the initial aims of identifying these best practices was. So hopefully a lot of you on the call will be able to participate in that program in the year to come as one mechanism to move forward with improving our system of care. And the ultimate outcome of that would be a Michigan EMS systems have access to a toolkit that they could use to adopt in their own individual system to optimize both process variables and outcomes. So all that said, all that work that we've done over the 5 or 6 years in terms of optimizing our system, this year we basically got a punch in the face. And that punch in the face is really, as everybody knows and is well aware of, the COVID pandemic and how that is really already affected our processes and outcomes within this calendar year of 2020, and how it's going to affect it in the year and years to come is really what we need to talk about and strategize and plan for, and hopefully one of the main outcomes of the meeting that we're going to have today. We don't have data to present year to date on how the COVID pandemic has impacted cardiac arrest care or out-of-hospital cardiac arrest care in the state of Michigan because the data is really just too preliminary. But I think you're going to hear from other presenters today some evidence of how that impact has been brought forward. I'm going to just share a few things of at a higher level of how this impact may be affecting us both here and nationwide and internationally, and then a lot more discussion will follow with our invited speakers. So how has COVID affected the incidence of cardiac arrest? So this is one study that was published in the New England Journal in northern Italy, the Lombardy region, where they actually published how the COVID outbreak impacted their incidence of out-of-hospital cardiac arrest. And the graph here on the vertical axis is, on the right side here, is cases of out-of-hospital cardiac arrest per 100,000. Remember, our number actually was a lot higher at baseline of 84, but their baseline of incidence was much lower in the year before the COVID pandemic, and almost doubled in the days after the COVID pandemic on a day-to-day basis, and that correlated with the incidence of COVID cases. So this data suggests, at least in their country, that the COVID pandemic was associated with an increased incidence of EMS treated out-of-hospital cardiac arrest. It's not quite clear how much of that is directly related to the COVID virus itself versus people being reluctant to access EMS when they have symptoms that could lead to a cardiac arrest, and potentially a contribution to this is deferred care for medical emergencies as well as the COVID virus infection itself. Recently distributed by the CARES Advisory Council on 5/11 was some look at the national CARES data and how the COVID pandemic might be impacting that. And some of the data that they presented was that there is a decrease in presenting shockable rhythms from 17.5% to 14.4%, which multiple ways to potentially interpret that, but one way is, again, further delays. There could be delays in getting first rhythm analysis, because oftentimes the longer you wait to do that first rhythm analysis, the less likely it might be to be VFib. It could be also that different causes of the causes of out-of-hospital cardiac arrest maybe the respiratory causes might be increased due to the COVID virus, which again could change that proportion. Obviously, with stay-at-home orders, the incidence of cardiac arrest in a public setting, you would anticipate decreasing, and it looks like it's gone down preliminarily from 18% down to about 12%, which has significant implications in our strategies moving forward. We might want to think about focusing on cardiac arrest at home in the coming years as a mechanism to have a bigger impact on our outcomes. Also, they saw a decrease in bystander AED application in public locations. So again, maybe a hint that there is reluctance to participate in care, but that really isn't panned out in the bystander CPR rate change, which I was surprised to see so far has not declined. It is about 40% nationally. And then there was an increase in field termination, which I think is related to, and Dr. Fales will talk about for the state of Michigan, related to some changes, at least here, in the field termination criteria during the peak of the pandemic. The other thing that happened is that ILCOR took it on to do a very rapid systematic review of some of the issues related to protecting providers during the treatment of out-of-hospital cardiac arrest and in-hospital cardiac arrest. I'm just going to highlight a few of the recommendations that came out of ILCOR that might be part of our discussion. The first was that even though the data is very limited, there is some data that suggests that both chest compressions and cardiopulmonary resuscitation may have the potential to generate aerosols, which could impact the type of PPE that's required, elevating it, from droplet precautions to aerosol precautions. There was really, based on more expert consensus, that we want to really make sure that we suggested that lay rescues continue to do CPR and public access defibrillation, with the caveat that chest compressions alone would be appropriate. However, there also was the caveat that considering giving rescue breaths to infants and children, especially when lay rescuers are willing and trained to do so, because of the higher incidence of respiratory arrest in that group. And then again, very key for healthcare providers is suggests that healthcare providers should use appropriate PPE for aerosol generating procedures during resuscitation. And that really relates to N95 protection, as well as things like using viral filters in advanced airways. And then finally, probably the most controversial issue is this question of defibrillation before having aerosol generating procedure PPE, because the timing of defibrillation is so critical in improving outcomes. Even a delay in donning PPE could impact the effectiveness of that intervention. There really wasn't any data at the time that whether defibrillation does or does not contribute to aerosol generalization. So this really was a challenging recommendation to consider, but it's something that will be an ongoing issue in terms of the timing of defibrillation relative to PPE for EMS providers. So moving forward, and I'm just about ready to wrap up, is I think one of the things, every year when we did our Save My Heart conference, we looked at our data and we strategized about how to move forward in the coming year to optimize our outcomes. And I think, this year is going to be very, very different in terms of how do we strategize in terms of optimizing outcomes in the background of a respiratory COVID-19 pandemic that has challenges both to the patients themselves, but also protecting the providers as we try to continue our efforts to improve cardiac arrest outcome. And I think one of our goals of the conference today is really to leave with some strategies and tactics that we're going to deploy in the coming year to optimize our outcomes during this very challenging time. So I'll end with my reminder of, if we succeed, we will save one extra life every day here in the state of Michigan. And I appreciate all the efforts of everyone across the state in terms of participating with Save My Heart to trying to achieve this goal. And with that, I'll take some time for questions.
Thank you so much, Dr. Newmar. That was terrific. I'll have you continue to share your screen in case you want to use any of your slides to answer some of your questions.
Sure.
So one of the questions in from the group is, in identifying the variability in survival across the system, does your graph have a minimum number of cardiac arrest entries to be considered? CARE suggests that there should be at least 100 cases to make sure that the variability is not due to low numbers.
Yeah, so we have a minimum of 50 cases for the EMS agency criteria. So you can see that for this example here is the variability in survival. It's CARES agencies with greater than 50 non-traumatic cardiac arrests in 2019. And then for the hospitals, it's at least 5 admissions. So CARES hospitals with greater than 5 patients admitted.
Great. And then there's another question. It would be interesting to understand what trends you are seeing when the analysis is restricted to the Unstein group bystander witness, VF.
Yeah, so we do have that data. I don't have that data in the graph. And I don't want to speak to it specifically without having, because I can't remember exactly what the trends are. Yeah, so I do believe, and maybe Terry can chime in here, that we compare fairly favorably to the national average in that subgroup. Terry, do you remember what that number is? We'll try to get it before the end of the conference.
Okay, yeah, like I said, we'll try to update some things on the website too for the questions that need to be answered. And then there was another question about variability. Is there something that can be done, kind of, I'm summarizing the question, is there something that can be done to kind of limit that variability across, hospitals or agencies? What would be the biggest factor in kind of reducing that variability in survival?
Yeah, so we actually, in reducing the variability in survival, we really don't know any one factor. I think it's probably unlikely to be any one factor. I really think when you talk about the survival, it's going to be really optimizing the entire system of care, including the bystander response, the EMS, the 911 dispatch, EMS care, and hospital care. And really, any one system might be only as strong as its weakest link. Part of that EPOC program that I tried to highlight is that that really is focusing on EMS, but it's gone to basically interview systems where they have high survival rates and interview systems where they have low survival rates, and try to identify both the factors that are associated with the high survival and the barriers that are associated with low survival, and then try to disseminate that. First of all, validate that related to outcomes, and then try to disseminate that as a toolkit that systems can then use to adopt to optimize the outcomes in their own system. Now, the challenge obviously is each individual system. Michigan is a very diverse state in terms of both population density, in terms of sort of rural, urban, suburban, and even diverse in the resources that each medical control authority has. So, part of the challenge of even if we know figure out the things that are needed to optimize outcomes, we need to also identify the resources to do that.
Great. I think we have time for one more quick question. The question is, do you think the bystander CPR rate didn't change because of more arrests happening at home during COVID?
That's a great question. I think, yeah, if you look at the percent of arrests that were in a public setting, it looked like 85% of the arrests in the COVID period were at home. So yes, I would agree that the likelihood of someone still being willing to do bystander CPR, if there's someone they're already living with and know, would be less likely to be impacted by the risk of acquiring a COVID infection than someone who you see go down on the street. So I think that, yes, the fact that the 85% of the arrests so far were at home would be much less affected, if it maybe not affected at all by COVID, but there's still that other proportion of arrests in the public setting, which actually is one of the biggest sources of our survivors. And we really still need to deal with how to advise the public and support the public in doing CPR in the public setting. And I think Michael Sayre might be addressing that in his presentation, because I know he has a recent paper out in circulation addressing that.
Well, that's terrific, Dr. Newmar. Thank you so much for that talk and interesting conversation afterwards. We can talk more about this in our panel discussion. I'm going to go ahead and take over the screen one more time. All right, and what I'd like to do is take a moment to do one more poll question. So I'm going to launch a third poll. And the question is, how confident are you in your safety while caring for out-of-hospital cardiac arrest patients during COVID-19? So go ahead and take a minute or so to kind of answer that question. We're about 2/3 of the way through, so I'll wait for a few more answers, and I'll kind of verbally describe this. It looks like the majority of people are at least somewhat to fully confident who actually manage patient care. So I'm going to end the poll there. I'll share the results if you can see those. And while we're looking at the poll results, I want to introduce our next speaker. It's Dr. Marcus Ong. He comes to us from Singapore, so it's 12 hours ahead. We really appreciate Dr. Ong taking the time after a long shift and a long day to help us understand how COVID may have impacted your country of Singapore. So Dr. Marcus Ong is an associate professor, senior consultant, director of research and clinical scientist for the Department of Emergency Medicine in Singapore General Hospital. We truly thank Dr. Ong for joining us from Singapore, and his talk is entitled Protecting Staff and the Emergency System During COVID-19 in Singapore. So Dr. Ong, you can go ahead and start sharing your screen.
Thanks, Jim. I bring you greetings from your friends in Singapore, and thanks to Dr. Newman especially for inviting me to have a chance to share this time with you. Jim, you okay? You can see my screen? Yeah, okay, great. As Jim introduced, I'm an emergency physician from Singapore, and I also serve as National EMS Medical Director. And what might be of interest is I run a research program that includes health services research focus, as well as I run the data science team for my health system. So today I'm going to focus on two basic themes. One is how do we protect our staff and our system during a pandemic. And then secondly is some of our key learnings from our experience so far the last 5 months fighting COVID, and how does that apply, for example, to cardiac arrest. So for those of you who have not been to Singapore, we are a small island in Southeast Asia, population 5.4 million, one of the most densely populated countries in the world. And we are a major international travel hub. So in fact, we have direct air connections to Wuhan, for example, which is 4 hours flying time with several flights a day. So we were actually one of the earliest in the world outside of China to report COVID-19 hitting us, and that was in January of this year. And the background to our EMS system is that we run a fire-based EMS, very much like many of your systems in the US. It is a single dispatch center that covers the whole country, a single uniform EMS service. And about 10 years ago, we started on a journey to understand our EMS system, and we came up with our first 5-year plan on improving our EMS system and improving survival for cardiac arrest. At that time, we had a very, very low survival rate. It was only 2% survival for cardiac arrest in the whole country. And what I'm presenting here is something that we call the frame of survival, which builds on the chain of survival concept. So you can see that there are 4 main elements in the chain: community, dispatch, ambulance, and the hospital. And as we all know, that they are intricately linked. And what we did was we went through an exercise to identify the gaps that existed in our system and target them for intervention. But beyond that, we also have what we call the inner frame of survival, which refers to what the EMS system has direct influence over. For example, your culture of excellence, EMS leadership, training, protocols, etc. And there's also something that we call the outer frame of survival, which are things that are beyond our direct control, but within our sphere of influence, whether that's political commitment to the emergency system, legislation, and community attitudes or cultural kind of norms. And we use this frame to actually map a strategy, identify barriers that you can see on the left, and we work with the Global Resuscitation Alliance on the Seattle concept of the 10 steps to improve survival. And what that resulted in was basically, we are now into our second 5-year plan, where we actually put in place a series of steps of interventions that have built one on top of the other. I think the first thing we got right was we started a national cardiac arrest registry in 2004. And since then, we have actually built on things like you can see at the bottom here, adding mechanical CPR devices on our ambulances. And we do that mainly as a crew and staff safety kind of issue. We regularly dispatch fire bikers, which are firefighters on a motorcycle with an AED. And in our highly urbanized setting, we have shown that we can actually reduce response times by half and get an AED on scene. We started a dispatcher CPR program in 2012 and added a QI component. And I think this was one of the major things that drove the increase in our bystander CPR rate. READY is a basically national registry of AEDs that we started in 2014. And this links with the app that we have for activating volunteer first responders. More about that later. We also introduced in 2014 our DARE program, which is a community CPR program that started initially in schools. And then added things like intraosseous for the EMS service. A key piece of this is the My Responder, which is basically a first responder app. We now have something like 50,000 volunteers on the app that will activate you if you're within 400 meters of a cardiac arrest. And in 2015, we started a major AED program that we call Save a Life. So we've actually placed AEDs in one out of every 2 residential blocks in the country. And again, the background is 90% of my population lives in public housing, which are multi-story kind of apartment buildings. And so we thought by doing this, we would actually be able to cover 90% of our population. We expanded our community training in 2015. 2016, we brought in something called the CPR card, which we are equipping volunteer first responders with a credit card size device that gives feedback. And then now we've actually, out of the charts, we have, in the last 2 years, introduced high performance CPR program for our first responders, manual defibrillation for pre-hospital providers. We are bringing in basically the impedance threshold device. So what has been the impact of all these programs over the years? We have actually seen a dramatic rise in our bystander CPR rate from 20% to well over 50% over the space of about 5 years. We've seen our survival go from 2% to is about 23% now. And on average, we are saving 200 plus extra lives a year. Now back to COVID-19, and with that background, we will keep that in mind for a while as we talk about how COVID has actually impacted Singapore. So you can see that in January, we already started to have people, or mainly tourists at that time, coming in from China that were picked up at our airport temperature screening, and they actually started some local chains of infection. And this actually led to some border controls, and we had to actually activate our major pandemic kind of program that we call the DORSCON, disease outbreak condition level. And we raised that from green to yellow to orange, which is where we are now. And what I'll do is I'll actually show you how the outbreak has progressed over the last 5 months. And you can see that it has actually hit us in 3 major waves. The first wave was actually imported cases coming in from China. And these were mainly tourists. And they actually brought the infection with them. A lot of them were actually, we now realize, asymptomatic when they left. But then they started showing symptoms when they came to Singapore, and then ended up getting admitted into our hospitals, our ICUs, into our quarantine facilities. The second wave was actually a community-based kind of spread that were initially those that interface with these tourists. So tour guides, taxi drivers, bus drivers, the sales girls, at retail outlets. And then this spread to their immediate family members, and then into churches, for example, and into social settings, karaoke kind of groups. And the third wave was when actually went into our migrant worker dormitories. So I'll speak more about that later, but this has been the major wave that we've been dealing with. So as you know, it's a global phenomenon, and Singapore has not been spared. to date, we've had about 30,000 infections. But as you can see, we've managed to actually keep the curve relatively flat throughout this period. And I think the major challenge that we are facing, that we now understand from the science, is that we are dealing with a very tricky opponent. So this is data out of China, but what I think it reflects, which is pretty much in line with what we found with our local Singapore data, is about 30%, even up to 50% of cases will be actually asymptomatic. And they actually do have a period of time that they are contagious and can spread this. Another 50%, the majority will actually have mild to moderate symptoms. And of course, they do have a pre-symptomatic period where, again, in the first few days, they are highly infectious. And then about 10% of them will have severe symptoms that require oxygen, for example, and hospitalization. And their contagious period will last longer. And then finally, you have about 5% that will have critical symptoms, require ICU level type of care, and your major mortality actually comes from this group. Now, despite having these major outbreaks and 3 waves, we've actually been able to keep our mortality very, very low compared to our region. And to date, we have 24 deaths out of 50,000 cases. I think basically what this reflects is that, number one, there's actually inadequate testing and reporting in the numbers that you see globally. So if you look at the numbers that are at WHO on the newspapers, I think those are actually a mere fraction of the actual incidence or prevalence rate that is going on in the community out there. Now, for Singapore, we've actually taken a very aggressive stance in terms of testing, detection, and tracing. And because we have actually been able to track most of our cases, we now understand, for example, that COVID is actually a 3-phase disease. Week 1 is the acute phase, as you know, where they start to have from pre-symptomatic to become symptomatic. And then those that actually require oxygen or are going to require extra care will actually show up in this period. Week 2 is the critical phase, where those that actually need oxygen will peak and the ICU cases will start to come in. And then week 3 is the recovery phase for the majority of the patients. And they can actually have a long tail where they continue to actually test positive PCR for a period of time. And the other thing we have realized, this is local data from Singapore, is that it's a very age-dependent disease in terms of the outcomes. So practically, we have had no deaths or major even admissions requirements for oxygen in the group below 35 years of age. However, if you go to the age that the group that is age of 65 and above, you can see that the requirement for oxygen hits 30–40%, and the ICU rate is 20+%. So indeed, there's an important role that age and comorbidity has to play. And so the major thing that we are dealing with now is an outbreak within our migrant worker dormitories. Now, for your information, the construction sector and many of the labor-dependent sectors in Singapore are heavily dependent on migrant workers. And they actually live mainly in purpose-built dormitories that are military-style barracks. So you may have several thousand men that are sharing, for example, 10 to a room with common bathrooms. And these are like small cities in themselves with their own department store, sports facilities and movie theater. And they all live in very close proximity. They share their food, they are in communal type of living. And what happened was we had a major outbreak in several of these dorms. And what we've realized later on is that workers from different dormitories would be working on the same construction project. So you might have a team that is doing, for example, the ground laying work that is from dormitory A, another one that's doing the electrical work that is from dormitory B, another one that is doing the plumbing or the waterworks, right, from another dormitory. And so they all came into contact at the workplaces as well as during their recreation. So we've actually had to launch a major operation where we've mobilized whole of government. We actually put a general in charge of the whole process, mobilized teams from both the public and private sector to go into the dormitories and basically start testing, isolating, separating the healthy from those who are not, and looking at rehousing them and basically treating them. And so we've actually used, for example, our exhibition halls, which we overnight in a space of I think 5 days, converted to a facility, that community isolation facility that can take 5,000, 10,000 people. We've used cruise ships, we've used old school buildings, and basically have to be very creative in how we've actually been able to manage this big challenge. And what has been the net outcome of this? So to date, we have had, like I mentioned, over 30,000 cases, but the majority of them, 26,000, have actually been discharged from the isolation facilities. There are 12,000 that remain in community facilities, and as of date today, less than 200 are actually in the hospital. So I just want to point out that 90% of the cases were actually treated and isolated in community isolation facilities, where there was, for example, no requirement for oxygen. It would be mainly a nurse that would treat them, and maybe a doctor who does rounds, at a medical post, and that's it. But we've managed to actually protect the healthcare system and, keep our beds and our ICUs available. To date, we have had maybe about 40, 50 cases that went through the ICU. And today, I'm glad to announce we only have 2 patients left in the ICU, and deaths is now at 24, as I've mentioned. The other thing that I want to point out from this slide is that our contact tracing and linkage rate is over 90%. In other words, we are fairly confident that we pick up more than 90% of all the infections in our community. And that's through basically a good old-fashioned public health and detective work, contact tracing. In fact, the contact tracing is majority done not just by healthcare workers, but also the police force. And we use various methods that are more like crime solving to actually do our contact tracing. So I'm going to move on to how this has impacted EMS, and you can have a look at how our standard attire is during this period, with the N95 or respirator, mask, goggles, and this is for cases that we think are suspect cases, the disposable gown, and we've actually done away with the shower cap, as I will show later. And so very much fire-based EMS, as you can see. How has this impacted our overall call volume during this period? We've actually seen a drop in our EMS call volume by 10 to 20% during the peak of the wave of infections. But that has actually recovered now and actually rebounded slightly. So we're actually back to almost business as usual. In terms of the types of cases, P1 are our most severe kind of calls, your echo type of calls in the US. Your P2s are the yellow. And you can see that P1s remain more or less stable while there's a drop in the P2s. And the green is the P3s that actually dropped for a while and then has actually come up again. And we are almost at business as usual kind of levels now. Of course, what is expected is the number of suspected COVID-19 conveyances actually increased over the period. And to date, actually, a lot of these are now driven by the dormitories that have known positive cases that might have, for example, some new complaints. For example, we are dealing at the moment with a dengue co-infection with our COVID patients. And so they would actually get activated to transport our patients to the hospitals. Now, one of the things I want to touch on is actually crew protection and staff protection. And I know that this has hit many communities in the US and Europe very hard. And so this is something that is very dear to our hearts as well. So I want to say that, we have about maybe 40 healthcare workers that have tested positive over the last 5 months. But the majority of them, over 90%, we think were actually infected in the community. In other words, through their social contacts or their family, rather than at work. And there were only 4 cases that remain unlinked that we think could possibly have been at work. And in fact, majority of these were the security personnel rather than the healthcare personnel. And to date, we have no healthcare workers that have required ICU care or even oxygen, and of course, no deaths. And what is interesting is this case study that we published quite early on in the outbreak. So early on in the outbreak, we had a patient that was brought in by EMS for a complaint of pneumonia. And he was admitted all the way from the emergency department through the hospital into the ICU and was intubated. And only in the ICU, the patient was actually swabbed and turned out to be COVID positive. And so, of course, you can imagine a lot of concern in the hospital. We actually traced back, there were at least 40 to 50 healthcare workers that had direct contact with the patient, including aerosol generating procedures. And we of course called them all in, swabbed them, tested them, and any guesses the number of healthcare workers that were infected? So the answer is 0. None of them were actually infected through this patient. And the reason is that we believe we had actually activated our universal kind of precautions very, very early on. So in my hospital, the minimum PPE level is a surgical mask. So in fact, this has been standard of care for more than 10 years. So for example, my good friend, Dr. Brian McNally, spent a year with us in Singapore, and he knows that every day when he comes to work, we have to force him to put on a surgical mask. And so the majority of the patients, the healthcare workers that had contact with this patient were actually only wearing a surgical mask, and of course, emphasis on hand hygiene, using your alcohol rubs on the hands, not touching your face, and none of them got infected. And the minority of them were actually wearing an N95 at that time. So I think this gives us a lot of encouragement and to show that, basic measures actually do count a lot. So this is our current EMS posture for PPE, standard N95. So basically our posture has been that we treat every case as infected unless proven otherwise, similar to your blood, universal precautions. Goggles and a level 4 gown. So this gown is a disposable gown that we will actually reuse unless basically it's confirmed on patient contact that this is a suspect case. So in other words, when we get the 911 call, for example, you would not know what the complaint is, and we would go in blind, and we would have the highest level of PPE posture. But coming out then, we would have taken a history, examined the patient, we would have access to their electronic medical records. We know whether they had a COVID test in the last few weeks. And then if they were positive or high suspect case, we would discard the gown and discard and do a high level of decontamination. If it was a non-suspect case, then they would actually be able to reuse some of their PPE, but they would routinely disinfect the ambulance as per usual. And we have done away with the head covers and the shoe covers. So, pop quiz. What's the difference between the American superhero and the Asian superhero? And I think the answer is there. The Asian superhero wears their mask on the face, on the mouth, not the eyes. And so again, I think this is something that is a bit of a cultural kind of issue that I want to share. So, which is that even on a normal day, it is quite acceptable in my society to wear a face mask if you are having, for example, an acute respiratory infection on the subway or in the, in public. And so for us, it was fairly acceptable, when we actually moved to universal masking. So today, by law, if you step out of the house, you have to be wearing a mask unless you are running or you're doing heavy exertion, physical exercise. So this is one of the culture. And also at the hospital level, as I've mentioned, since the outbreak of SARS in 2004, it has been standard precautions for us to wear a surgical mask whenever there is patient contact. And then we actually step that up according to the risk level. How has COVID impacted cardiac arrest? And you can see our numbers have actually remained more or less stable. We have not seen an increase. In fact, we have seen a slight dip, maybe about 10% in our month-to-month numbers of cardiac arrest. In terms of bystander CPR, maybe a slight drop, but we are still well over 45%. In terms of when you add on the dispatcher-assisted CPR instructions, then well over 60 to 70% of the cases will get some kind of CPR before EMS arrives. Our AED rates have also remained fairly high in terms of public application. And I think there is an increase, as I think Dr. Newmar showed, similar in Singapore, of residential arrest. But I think because we started early with a residential AED program, I think that is starting to pay dividends. And our ROS rate, again, we have to remember that in my setting, we do not pronounce death in the field and very rarely have termination of resuscitation. So our ROS numbers are typically half of those in the US comparatively. Okay, so some interesting ideas that we are working on, which is an evolving concept, which is a CPR protection kit for rescuers. So we're actually working on putting these with the public AEDs, or equipping our volunteer first responders that are activated by our app with these. So it will have a kit with a face shield, gloves, the CPR card for CPR quality, some disinfectant wipes. And then how this would look like is that you would actually be able to put this on while you are activated and go and respond to a case. But what you might find interesting is this is what the victim would have. So we are playing with two prototypes. One that is a mask kind of concept that you put on the victim, which has the usual kind of filter which you can actually ventilate the patient and give mouth to mouth or back valve mask through. And this is the shower cap kind of version that you put on. And we've tested these, and we're looking at the field trials at the moment. Now, moving on to the ED, we basically have based our response on, a conceptual framework that looks at staff, supply, space, and trying to align our workflows with both the local and the national kind of level, and emphasizing on frontline staff protection, the ability basically to recover to your steady state, and your situational awareness and perimeter defense. So to let you know what that looks like is that in every emergency department in Singapore, we actually divided into three areas: the green, the yellow, and the red. This is not in terms of the priority of care, but in terms of the infection risk. So red are for positive cases where we have negative pressure rooms and isolation facilities. And yellow is where we treat the suspect cases, usually with acute respiratory infections. And then green is our normal business as usual areas. And this is in the emergency department. And it follows through when you admit the patient into the wards, whether it's the general ward or even ICU facilities, that we have that same kind of differentiation. What does this look like in practice? This is the front door of my emergency department, and what you are seeing is the fever area. So we basically literally split the department in two halves. This is the fever section with a negative pressure kind of rooms. It's fully equipped with priority 1, 2, 3, has got a pharmacy, radiology, everything built in, and they don't come in contact with the normal stream of patients. This is the perimeter defense that occurs at the hospital. You can see the thermal scanner over there. And this is routine at all the entrances of the hospital. We have also restricted visitors, for example, where at the ED, maximum 1 visitor per patient. This is an example of our fever screening area, the priority 3s, where they walk in. And we basically built this in like 5 days, converting our ambulatory surgical area into a fever screening area. And so each person has an individual cubicle. The staff can go in, they get swabbed, tested, and we have a PCR turnaround time of about 3 hours. So in 3 hours, we know you're positive, negative, you get admitted to isolation facility, or you can be discharged. And this is what we call our made in Singapore swab station. So it looks a bit like a telephone booth. The idea is that we preserve our PPE because the person who's doing the swabbing is actually protected, and you can actually do multiple swabs of patients in an hour without need to change PPE for each case. Okay, I've tried to speed up a little bit, and just some highlights that our attendance at the ED has also dropped. P1 has remained stable, but most of this has been driven actually by reduction in chest pain type of cases. And of course, instead, if we have seen more pneumonia and infections, this is my health services research hat, where we are actually working on a conceptual model of the whole healthcare system, looking at the impact not just on COVID but non-COVID, and we basically built some data science infrastructure around this to build our system dynamics models. This is what it looks like, and we've actually been using our models to advise both the Ministry of Health and my hospital system, and we're actually working on things like how many isolation beds do we need to maintain over the next 2 months, for example, how many ICU facilities, how do we transition back to business as usual, the usual typical epidemic kind of curves that my team has produced with the confidence intervals and the scenario kind of sensitivity testing. I'll just pause a little bit at this slide to say that, this is what we actually had in terms of epidemic curve. And we actually modeled what would have happened if we had not actually implemented things like social distancing, contact tracing, and quarantine. And you can see that the story would have been very, very different. We've also driven a lot of innovation through this period. So for example, 2 major apps that we've come up with is number 1, the Trace Together, which is basically a Bluetooth based application for your phone. And we have now at least 1/5 of the population that is on this app, which actually locks all the contacts that you have with another phone that has this app built in. So in other words, it's very easy to actually trace back your contacts. They are anonymous, it's based on the phone IDs, and you only pull out that information if the person is tested positive. Another one is what we call safe entry, that is at the entrance of the hospital, emergency department. In fact, when you go to the bank or your hairdresser, you take out your phone, scan the QR code, and then it logs in where you have been over that day. Okay, and some things moving forward, mobile swab stations, drive-by swabbing, telephone booth kind of swabs in public areas to actually expand our testing capability. This is my second last slide. And our team has actually been modeling 3 scenarios how COVID-19 could play out globally. So one is a single wave, which we think is the least likely. What we are preparing now is actually repeated waves. But because we've had experience with the first wave, we think the second, third wave will be more attenuated and will be blunted by our public health response. And the last scenario is, I think, increasingly a reality, that we could see an epidemic turn endemic. And basically, you never can really get rid of COVID-19, but they'll always be there and can flare up at any time. So a nice conceptual model that we are building to actually think about things is the first wave, which are mainly the COVID patients. The second wave, which we are now getting into, where there's a resurgence or rebound of your non-COVID cases. And then there's a third wave that will come with chronic care patients that have delayed care and interrupted care. And of course, the fourth wave is actually those with psychiatric, social, and economic kind of consequences. My take-home lessons. Number 1, COVID-19 will be a test of 3 things: the healthcare system, the government response, and social capital. How well your population is able to cooperate and embrace public health measures. Preparedness matters. So for us, we've had pandemic plans for more than 10, 20 years, including legislation that was ready to be activated, mobilization of resources. We've been stockpiling PPE for years, and we had enough supplies that our frontline was never short. And we were able to actually activate a whole of government, whole of society response. And the fact that we had no deaths for healthcare workers, I think, is a reflection of that. So indeed, it's not just about protecting lives, but also protecting the healthcare capacity so that we are able to deal with the non-COVID and the chronic patients as well. I believe firmly that no healthcare worker should die because of their work. And my last words would be that this is not going to be quick, it's not going to be pretty, but in order to effectively deal with things, we need to have a paradigm shift in our thinking. The world has changed, and we need to actually adapt to be able to survive and thrive in this. So thank you very much, and I'll exit from my screen here. And
thanks so much, Dr. Yeah, thanks so much, Dr. Ong. If you want to hold on to your slides just for a second in case you want to answer any questions with your slides. We let Dr. Ong go a little bit past his time because he's not able to join us for the panel discussion later on. So we just really are grateful for his time today. Amazing insight, Dr. Ong. You have amazing numbers, low death rates, low transmission rates, despite a very dense population. Compared to the US, what do you believe are the top 3 interventions in Singapore that reduce the transmission and mortality rates?
Okay, so again, this is a loaded question, and I don't presume to tell my American friends what to do. But maybe I'll just reiterate my first point, that was in my summary. I think the 3 key pillars of any response, societal response to a pandemic, is the test of your healthcare system, your government response, and that kind of social capital that you have. So in other words, it's all about public health. How much investment have we kept and maintained in our public health systems, both surveillance, detection, contact tracing, isolation, and the ability to respond there. And also it's a major test, of course, of leadership, as you know, that leadership matters in such a time. And finally, the the social capital, where basically I think the strength of our society has been that even though we are very multicultural, multiracial, we've been able to actually build a social compact where there's an understanding of the common good that supersedes the individual rights, and that we are prepared to actually put aside some of our individual inconveniences for the sake of actually the greater good. And so this has been very effectively communicated all the way down from the Prime Minister, to through regular broadcasts, regular communications. We have a daily press conference where we'll actually update everyone on the numbers, and we have a lot of transparency in terms of what is happening and the number of cases reported, etc.
Great, thank you. And then we have time for one more quick question, and that is PPE question. It's the shortages are something we've really struggled with here in the U.S. Were you having to reuse N95s, or did you have any problems with your PPE stockpile going forward?
Right, very good question. And again, I think this is another key, factor. As you know, all of us who are exactly in the disaster kind of business, this is where the rubber hits the road. So we've actually had pandemic plans and PPE stockpile for many years. We don't just stockpile PPE, we stockpile drugs, ventilators, food, because we are not a food producing country where most of our food is actually imported. So all these are actually part of our routine precautions. So no, we have not had to recycle PPE. I think it's a bit unthinkable for us. The other part of PPE security is that you have to look at local manufacture as well. So we've actually maintained manufacturing facilities, even though they were not really profitable for a long time, where we produce our own N95 masks and surgical masks. And so now these are a variable strategic resource where we actually control our own production. Okay, I see one more question, Jim, on the chat, which was asking about whether any measures were instituted in firehouses to diminish responder to responder spread. And maybe I can just address this as a last question. So sure. Yes, this is actually crucial. So besides the frontline staff PPE posture, meaning that, gowning up and masking up when you go for your call, the other key component is actually what happens in your teams, whether it's in the EMS, in the firehouse, or in the emergency department. And what we have done is actually move to a team-based kind of approach. So EMS is quite familiar with this. We work in rotas, where rota A, B, C, D, they don't mix and come into contact with each other. You come to work together with the same team, you go home with the same team, and you only interact with your immediate team members. And of course, all our conference calls and all that are on Zoom. The second is that the single highest place where we have found the risk is actually during meal times. And so it's mandatory for us at work to wear a mask, even when you're not on a call. But when you eat, obviously, you have to take off your mask. So what we have done is actually we've repurposed our dining facilities. We've actually spaced out the tables and chairs such that only one person to a seat, or actually put up a plastic perspex separator if it's a long table, and obviously eat in different timings, different shifts. And so when you eat, you take your tray, which is a bento set, or your own individual food portion. We don't have buffets anymore. You sit down, you take off your mask, you eat your own meal, you put on your mask, and then you dispose of your food. And so these are some of the disciplines that we've been able to actually put into practice, and I think is one of the key important success factors for preventing infections for staff.
Thank you so much, Dr. Ong. Terrific presentation and great discussion. And I really just appreciate your time and efforts to join us here today. So thank you so much. What I'd like to do next is we're a little bit behind time. I'm going to kind of fast forward through the next poll question just to give us a little bit more time and go right directly to our next speaker. Our next speaker is Dr. Robert Dunn. Dr. Robert Dunn is a professor of emergency medicine and EMS fellowship director in the Department of Emergency Medicine at Wayne State University. Dr. Dunn will be sharing the out-of-hospital cardiac arrest Detroit experience. Dr. Dunn, you can go ahead and start sharing your screen.
Good. Can you hear me?
We can hear you, Dr. Dunn.
Oh, good. Can you see my screen?
We see your screen. You are ready to roll.
All right, perfect. So first thing I want to briefly at least thank some of the people who were instrumental in trying to keep up with our data in this very busy, crazy times, particularly Shobi Matthew, our primary cares coordinator, and Damon Gorlick from our Medical Control Authority, of course, Terry and everybody else. I want to start just with the basics of kind of like, okay, here we were getting to the end of 2019. We were looking at our data. We were doing our kind of normal thing and to kind of catch everyone up on how we got to that point and then dive into what happened. So Detroit, big city, busy EMS system. Back in 2011, the city was bankrupt. Things were tough. We had some days as few as 6 functioning EMS units and a long-standing, very low cardiac arrest survival rate. We'd originally started keeping our own kind of homegrown registry starting in 2004. So bankruptcy ended in 2014. We started hiring more, and we decided we weren't doing things the old way. We decided we would come back with a plan to move forward. We had a city where EMS was embedded in the fire department, but our firefighters and fire responders did not participate in any patient care. We had no first responder program. We were the last city on the Journal of EMS's top 200 cities by population that didn't have any kind of first responder program. So we did that. We added a significant number of EMS units, and we added formal public-private partnerships to expand what we had out there. And during this period, we joined CARES as well, which was a really key step for us because it made it easier to maintain our cardiac arrest registry and continue to review our data. We made some steps forward at the 911 center because we had always been looking at bystander CPR rates, and they were very challenging. And we went to a current version of medical priority dispatch, and our main focus was on pre-arrival instructions, doing training, and reaching out into the community. And we started doing more peer review. We updated our monitors in 2017. And we put together data and research committees as well as weekly peer review on top of our more high-level CPR data reviews to really provide feedback, often going out into the field, giving direct feedback to crews in kind of a low budget, I call it a DIY way. We actually are still primarily a BLS system, as people saw. We did some things to kind of enhance our BLS providers. One, we put ALS monitors on BLS trucks, which allowed us to kind of use BLS to the maximum extent of what's allowed under the scope of practice. We have BLS 12 lead program, so post-resuscitation, we can get a quick 12 lead that's sent out. We have waveform capnography for our BLS providers. We do use a BLS termination resuscitation protocol, and we've been exploring with a couple of our vendors doing some telemetry and telepresence. We've been tracking our data. We initially made, I think, some progress, and then we've been kind of in a plateau, and we've been looking at why that is and how we can continue to move forward. We participated in some of the work that Rob talked about earlier, really just looking around at agencies and things around the state of Michigan, our medical control authorities, and looking at variability and sources of variability and participating in the EPIC project as well to try and answer some of those same questions. One of the things that we did early on was we geographically targeted citizen CPR. So we looked at census tracts where you had a high risk of having a cardiac arrest and a very low chance of getting bystander CPR, and working with our partners at the university and the Center for Urban Studies, target these areas for CPR training and actually did door-to-door CPR training, piggybacked on our fire safety initiatives, passing out smoke detectors and CO detectors. So we got some nice press on that. We have seen our CPR rate increase from 14 to 40%, not quite where we want it to yet, but our call takers have made a big step forward in this and have really been participants, and we have tried to include them in all of our celebrations of survival. We summarized our work to 2016 in a paper a couple of years ago, kind of showing where we still had some opportunities and some things that we thought were at least some interim successes. We stayed focused on CPR quality during this period of time, but it was very challenging until we were able to get our new monitors and actually start providing some feedback. We moved to monitors that were giving some real-time feedback to our providers, and we were doing some rapid cycle training as well as individual improvement. We still had very old AEDs, which is why I have this picture of this metronome, because we were just using a simple metronome on our AEDs, and then we have subsequently moved to AEDs that also upload their quality data and monitor data into the cloud. So that's been a step forward. And then we can break this down and actually work with our providers so that we've been able to share this information. We've been able to share it across our hospital systems so they can look at some of the actual metrics for a patient, a survivor that was brought to them. They can learn a little bit more about it. If it was initially a BLS case, they can identify the initial rhythm, so it's not just shockable versus not shockable. And now that we have new AEDs, we can actually get that first responder AED initial rhythm for some analysis to help the care team decide what was really going on with that patient. And this has been a great step forward. It's still kind of a DIY. We have to literally have the cheapest option available just because that's all we could afford, and are making sure we're downloading every one of these. I was doing it for a long time. Shobi has been doing it more recently. So we actually have every single case with the CPR metrics and all the reports out of our case review system saved and then linked to our cardiac arrest run sheet so we can do some ongoing education with that. We feed these out to a whole team of people who does some reviews every week and comes up with some additional training, both for real-time reminders and our semi-annual training that we do on cardiac arrest. In addition, we recently purchased, and this was right before the end of the year, so we really haven't had a great opportunity to roll this out, but we now have CPR mannequins with feedback at every single one of our firehouses to do some pit crew CPR training on a asynchronous basis. Just, you know, we want everyone to do at least 15 minutes of practice every week. You do it whenever they can fit it into the time period. But that is something that we have been moving forward on, and as we got into COVID, it had taken its kind of more time out of our schedule than we'd intended. I just wanted to show this, and I'm not going to go through all of these. This is our 2019 data. So this is what I was doing right at the starting to look at this at the end of the year, starting to make sure my hospital partners were all getting their follow-ups in, like all of you who do this. And I want to specifically thank, again, Shobi Matthew and Dawn Nadow, who do a lot of our follow-up at our large hospitals, so they actually could get this information in there, so I have something even to share. So here I was doing this, going through this, looking at my survivors, and moving forward on that. And all of a sudden, we get to January. So January 23rd, we put out our first update to our providers. Many of our providers refocused on getting appropriate PPE if they felt that they did not have some. Many had fairly good stockpiles. You know, many people, as this was starting to unfold in January, kind of dusted off their special pathogen plans, dusted off their prior pandemic drills, looked at their after-action reports from 2009 and 2010, and really kind of tried to internalize those lessons. On February 1st, Detroit Metro Airport, which normally has a lot of air traffic from China, started which had been shut down, it was not one of the initial sites of repatriation, opened up as an official screening site and a destination for overseas flights, which kind of got us, again, regionally refocused on our special pathogen protocols, working with our hospitals, educating all of our providers about what was known at the time. On February 3rd, we had our first local health department, fire department focused planning meeting regarding the novel coronavirus. The health system started trying to figure out what they were doing in terms of in-system screening and assessment. The EOC at the state ramped up. The first positive test was 310, and then many people are familiar with all the changes that led to significant infection control measures being put in place in many states, but in our state in particular. When we look at what was going on with our protocols, we had special pathogen protocols, which were fine when we were first kind of starting out and doing a response to someone who was identified at the airport or at the land border. We have one of the busiest land borders in the US at the Canadian border here in Michigan. And that was fine to start with. As cases started to ramp up, we started to be more concerned about community spread. Our state model protocols were pushed out, covering some ground specifically related to viral transmission, enhanced safety, doing some things that we talked about for a long time. So I just want to talk briefly about a couple of these that we particularly focused on in our medical control authority, because it was clear even by then that we were having a fair number of cases in the community, is that we moved some of the interventions not to just being taken off completely, but moved them to post radio so there could be a discussion about what was going on in the case. There was a crisis standards of care CPR protocol that had 10 minutes to termination of resuscitation that came out as a state model protocol, which I'll talk about a little bit in more detail. We had a telemedicine protocol for low priority patients. This is something we were excited about that is, you know, if there's some silver linings here and there, it was showing that our telemedicine idea that we've been floating around for a few years but had never been able to operationalize actually worked. And we worked with our hospitals on our hospital status protocols. In our area, we do not allow hospitals to go on diversion, and we haven't since the early 2000s. And we wanted to refocus the hospitals on this because we knew they were starting to get stressed, to kind of realize that everybody's in the same boat and that the patients are going to be appropriately dispatched and destinations decided on, and that we would have regular check-ins with our health systems about how they were doing. This was our emergency special operations protocol, and I think Dr. Fales will talk a little bit more after later in the day about the development of this. But this was something added specifically when you're moving into a crisis standard of care. Triggers for crisis standards of care, I think, were an ongoing challenge, both in the pre-hospital and hospital setting across the U.S., and something we discussed regularly with our colleagues across the country and within Michigan. But this was something that you don't want to have to develop the protocol the day you need it. You want to have it out there and continue to provide some guidance to your local providers. So let's look at what was going on in the fire department. By 3/12, we had a EMS-run city employee response plan that if there were patients who were city employees, people who showed up ill at work, we had added a couple of EMS paramedic supervisors in a non-transporting vehicle to help with assessing them, help to do contact tracing if they turned out to be positive. We had a dedicated testing site that at the time we could only do 20 patients a day, but it was dedicated for the city of Detroit specifically. We had our first official exposure notification. Reportable diseases, as many jurisdictions do, are reported to anyone who got exposed. So our EMS providers who were exposed got our first notification on the 15th from a hospital. We had medical monitoring basically starting at that same time across our headquarters buildings and every part of the fire department. Other first responders followed up and did that as well. We had our first employee sick on the 19th that we sent for testing. We had our first firefighter ill, and they were in monitoring. The city purchased the Abbott Rapid Test and was able to have 1,200 tests a week, completely dedicated and run by the city through the health department. We had our first death in the fire department on April 8th, and by the 15th, we had enough testing capability that we were doing extensive testing in the community at nursing homes and homeless shelters using our EMS personnel. We had a total of 86 people positive in the fire department, including a number of ICU admissions and people who are still off. We have ongoing testing, not just to the fire department, but to the city of Detroit, tests every single city employee prior to any return to work, which is starting to happen at some of the offices, and then has ongoing testing for all the first responders. So let's look at the situation as it was unfolding in Detroit. On the left side, you see some Michigan counties, cases per 100,000, deaths per 100,000. Detroit is in Wayne County, Michigan, but has a separate health department under state law and has separate data as well. So the Wayne County data includes Detroit, but when we break out our Detroit data, we had over 1,600 cases per 100,000 and 208 deaths per 100,000. And we're really certainly the hardest hit place in Michigan and one of the harder hit places in the US. This is our epi curve looking at the dates. I really thank Dr. Rahman, my relatively new health department medical director, who basically dove right in and worked tirelessly and is still working tirelessly, but she was able to get this together and share it. And it really shows where we were seeing significant peaks of disease. So what was going on with us with our cardiac arrest at this time? So this is looking, and there's a lot of data we're still diving through. You know, when you're in the mountains and beyond the mountains, there's more mountains. So this is some great work done by Damon and Shobi Matthew on showing this. So this is looking at our overall cardiac arrest numbers. So 2018, 2019, definitely some gaps between those. 2019, we had a definite increase in cardiac arrest, but a very similar slope. You can see our 2020 slope takes, you know, following that epi curve in March and April, sharply increases and then seems to get back to a similar slope as the past. We also looked at our patients that meet dead on scene. Our dead on scene criteria also follows the state model protocol. And again, you see somewhat of the same information. And we've done a bunch of work with our medical examiner, but like many other places, we don't have a lot of information on some of these patients. We are in a process of diving into the death certificates on the ones that we have clear identities on and trying to find out some additional information, but that's something we really don't know. So then we started looking at 2019 versus 20 from the date of the first positive test. You know, when you get the first positive test in your community, there are obviously many people who are already infected, but you know, it was a decent arbitrary date to use based on our epi curves. So if we look at what we were seeing year to year, blue is 2020, the yellow is 2019. We saw some pretty significant differences in this is raw numbers, in the number of field terminations that we saw, the people who had ongoing resuscitation in the emergency department, and patients over 50. So this is looking at all cardiac arrests that were worked cardiac arrests, so things that will be in our CARES numbers next year. And this is looking at those same things as a percentage. We see a pretty significant decrease in advanced airway, and we could have a separate discussion about that because there's things that that I've always tried to get my providers to use our protocols more effectively on intubation. We had a significant increase in field termination, and actually we're trying to break that down because traditionally actually field termination is something that had not been that well embraced by our providers, many of whom have been providers for 20 plus years and have senior leadership who grew up in a load and go era where, every patient should be taken to the hospital no matter what. So it may be that we were actually doing some more appropriate field termination, and we're looking at each of those individually right now. This is looking at the change in the field termination crisis standards of care protocol. There is certainly days in the middle of April that we as a community were in a crisis standard of care. Our hospitals, our dispatch and EMS systems were maxed out, no units available, no mutual aid available. And as we look at the field termination, that from the date of the protocol being approved, we definitely see some increases at that point in time as well. And then this is the percentages broken down the same, again, comparing 2020 to 2019. So what are we doing with this now? Well, we're looking at things like visits prior to arrest. We have 49 cases we've identified where there was an EMS visit to that person prior to the episode of cardiac arrest that we ultimately responded to. And we're looking at each of those individually to find out what happened. Are these patients who refused to go to the hospital? Were they afraid to go to the hospital? What was really going on in those days? And of course, figuring out what's really related to COVID-19. I can step back and I can look at some of these big picture numbers and I can say, well, this is what we see when we had the maximum number of cases, but adjudicating each case has been an ongoing challenge for us in many other places. We do have some linkage to testing data because our health department is participating in this as well. We are working on death certificate data, and we're trying to find out a little bit more about those that are found dead, some of who we don't have information on who they were initially. So that has to get tracked back through law enforcement and medical examiner. Also, we are working through the CPR quality data. One of my questions is the time to first compression different? Looking at our bystander CPR rates, which I showed on some of the graphs, but are our EMS providers taking longer before their first compression starts, either because of PPE or other scene concerns? So, and we've thought about surveying some of our responders, but that's been challenging. So I just want to wrap up by talking about hospital interventions. This shows the data that we have so far for 2020, which shows that hospital interventions so far looked relatively similar. The N is pretty small on this. In addition, I like to point out that our hospital interventions have slowly changed over time. Rob Newmar earlier spoke about what's happening in the hospitals. I definitely, and our team really feels that we've got some challenges at the hospital level. And I just want to show you some, just briefly as we wrap up here, some of the things. So hospital A, these are interventions as a percentage of total out-of-hospital cardiac arrests they take care of each year. Hospital B, somewhat different numbers. Hospital C, very different numbers. So we still have a huge amount of variability in our hospitals that's gotten even more challenging during the COVID pandemic. We actually had been doing over the course of the last 2 years some regular education that went to our pre-hospital providers and went to our hospitals so that our hospitals can really work on modernizing their care, using their data. Many of them have the ability to use their CPR data, but do not. So one of the things I wanted to say in summary is that it's more important than ever to know what's going on. There was a lot of chaos for us during the worst weeks of the pandemic, and a lot more variability, EMS unit to EMS unit, a lot more variability, hospital to hospital, provider to provider about what was going on. And it's even more important to use that data and to try and tease that out. And we're trying to do it in a more real-time basis, I think, than we've ever done, is to really dive in, kind of catch up on some of the QA, because when we were kind of in more of a battle cadence, we weren't even able to have some of our regular meetings, or you'd try and have a conference call about something and it would get interrupted by calls from the field. So that's something that we're refocusing on right now. we really want to make sure everybody's keeping up with the science. So as we have additional increases in cases, we have a reasonable plan for responding to them and learn about, did some of the changes we make actually benefit patients? How can we coordinate better to improve hospital outcomes with what the hospitals are doing when they receive patients? And my kind of tireless thing, if you've heard me talk about this before, is I really feel the golden age of cardiac arrest research is right now, where we can make some serious changes. We look at the last 25 years, we've learned a lot, but haven't necessarily moved the needle as much as we should. So despite COVID, and many ways because of it, we need to stay focused on that as we move forward.
Thanks so much, Dr.
So
Dunn.
happy.
Really appreciate your presentation. Really commend you guys who are at ground zero, at least here in our state of Michigan, and the work you did to kind of save lives and keep this at the forefront. There are a couple of questions. One question was, let me see if I can pop it back up here. Just lost it. When you cite that you had patients seen by EMS prior to their cardiac arrest, what is your time frame you're using? Is it 24, 48, 72 hours, or weeks?
So we actually started by going back 1 week, and then we're focused really on the 72-hour period is looking, because what we saw is actually some people we looked back on their total utilization, and there was at least one person who had, over the prior months, 19 EMS visits prior to the episode where they had a cardiac arrest. So we focused down to 72 hours.
Great. I think we have time for one more question. When EMS is called to a scene, especially during the COVID era, what was their PPE that they were using, and was that protocolized? Sometimes when we see people in the ER, EMS people coming in, that's varied. Some people are full PPE, some people have a mask on that's barely fitting. What was your stance, and was it protocol driven?
So our largest provider, Detroit EMS, actually has an excellent compliance program, has been doing in-house quantitative fit testing since the bankruptcy. That's one of the things they put into place. They do their own TB screening. They typically have every provider fitted for at least 4 different brands of N95 masks. So when we first started putting out some information back in January, they kind of refocused on their supply chain. In addition, they had fairly large cache of masks and PPE. So they had a standard PPE kit. We actually did a video education with them. And most of the private providers that work with them follow the same guidelines. So they still have more than adequate supply. They actually had a better supply and more consistent, appropriate use of PPE than some of the healthcare systems they were transporting to. So, no one was having to reuse a mask day after day or anything like that. We did get a little short on gowns and coveralls, and we basically were focused on gowns, but we were able to source some locally made options before we ran out. So those were something that I think was really heartening, and is one of the reasons that, despite having 80+ positives, given that we have 1,500 to, maybe as many as 2,000 providers out there, that really did make a difference, and really they stayed very focused on PPE.
Terrific. Thank you so much. I think we'll end there. There is a question or two in the Q&A we'll try to get to offline, but thank everyone for all their questions. I want to move on to the next speakers. So our next 2 speakers are from Seattle and will co-present the next session. Dr. Thomas Ray is Professor of Medicine and Program Director of King County Medic One EMS. He is also the director of the Center for Progress in Resuscitation at the University of Washington. Dr. Sayer is Professor of Emergency Medicine and Director of EMS Fellowship at University of Washington and Medical Director of Seattle Fire Department. As we know, Seattle was one of the first hit communities during COVID. And Dr. Ray and Dr. Sayer, you can go ahead and start sharing your screen.
All right, Jim, can you see my screen okay?
Your screen is up. Dr. Ray and Dr. Sayer just needs to unmute if he wants to speak.
Okay, well, we'll try to keep Dr. Sayer on mute as long as possible.
I think that's a wise decision, Dr.
All right, so thanks everyone. Thanks to the organizers of the meeting, and thanks to Dr. Dunn for that talk. A really remarkable effort in Detroit, and quite frankly, all of the state of Michigan. You all are doing terrific work, and really a model for how a heterogeneous collection of stakeholders can do such good work together. So we're going to talk a little bit about, let's see here. I'm going to try to advance my slides. There we go. We'll talk about COVID-19 here in Seattle and Greater King County. I'll start off and talk just more generally about COVID, and then I'll turn it over to Michael to talk specifically about resuscitation. So as Jim mentioned, this was one of the first U.S. locales for where COVID outbreak really, I think, unfortunately took hold. And so we'll talk about that the first few days, some of our sort of lessons learned in terms of infrastructure and our strategies. And we'll talk just a bit about healthcare worker safety, some of the things we've done to monitor the system, and then go to resuscitation. So I think it's important to acknowledge that Michael and I are talking today, but it really has been a team effort. And this is just a few of the folks that have been critical in our response with regards to emergency care, and specifically pre-hospital emergency care. So just to give people context and orient, King County is the largest county, most populous county in the state of Washington. Regional hospitals, and they said, you know what, we got 2 patients with coronavirus infection, and the tests were sent off days ago. They've come back from the CDC, and sure enough, these patients have the acute infection. So I won't go through all the things that occurred that night, but it was a long evening, and it led to really a rallying of all the emergency preparations and the start of what we appreciate as quarantine and isolation for many of our EMS providers. So we, as people say, we were sort of building the plane while we flew it, and that became, you know, in hindsight, things may seem obvious, but as we went forward in the moment, there were a lot of important decisions, and I think sort of creating as we went along. So less than 48 hours later, then Monday morning shows up, and we now have 20 cases and 8 deaths here in King County and Washington State, and really the start of the COVID pandemic as it involves the United States. So some critical structure and strategies. I think, as Marcus Ong pointed out, public health really is the centerpiece here, and we were very fortunate to be integrated with our health department, that being our EMS system and EMS providers. And so we had a seat at this table, as many agencies and stakeholders did, and we really got a firsthand appreciation of all the activities that public health was responsible for, and quite honestly appreciated the integral role of EMS and our role to inform some of this, as Dr. Dunn pointed out, to do some of this testing and to be a marker or a measure of disease activity around the community. So as you can see, we worked hard to measure so that we could understand the epidemic here in our region. And in fact, EMS was involved in some of this work. And it was very interesting to see the CDC do their thing. They were out here very early on and worked in partnership with public health and were able to identify how the disease had spread early, and again, in the healthcare system and specifically in the skilled nursing facilities. So healthcare worker safety, this has been a priority, I think, for all the speakers, and been something that we've been quite interested in. So we've developed strategies for how to respond to patients in the field, for how to understand when we've actually had a patient, more than just our clinical suspicion, what to do if there's an exposure, and then how to keep folks healthy. And I'll talk just briefly about a couple of these. So again, we're fortunate here that our EMS system is embedded in the health department. And so we've been able to take the surveillance structure that's sponsored by the Department of Health and our local public health, which is the mandatory reporting of COVID positive and COVID negative results, and link those directly to our EMS records. And we're able to do this fairly real time, so with maybe a day's delay from the test results. And that's been able to really inform us about who has COVID and who hasn't, because certainly in the field, in the moment, you can't be sure based on the patient's symptoms and presentation. And in fact, we've been able then to track when we've had these encounters with COVID patients. And you can see going back to late in February and then all the way through now to more recently in June, how the number of encounters has sort of peaked and then decrescendoed here over the last several weeks. And at its peak, we were seeing upwards of 30 patients a day with COVID illness. So that led to challenges, right? As we understood, oh, here's a COVID patient, here was another COVID patient, we would go back and look at the EMS records. And we realized very early on that, these patients did not all have acute febrile respiratory illness. And so we began to look at, well, what were the dispatch codes for these patients who turned out to be COVID positive? And what we found really was that often it was non-specific. Yes, sometimes they identify themselves with difficulty breathing or a febrile illness, but just as often it was a sort of an ill-defined illness or something that was completely off targets, like a cardiac complaint or some bleeding or even a headache or stroke. So we took that one step further then and looked at the EMS records. This is of about 150 patients, the first 150 that were diagnosed with COVID who had seen EMS. And we looked at, well, this triad of did they have any fever, any cough, or any shortness of breath? Did the patients report this to the extent that it was written down in the EMS record? And you can see that it was reported in 71%, but that means it was not, none of these were noted in the other 30%. So then we took that one step further and looked at, well, what were the objective findings for EMS in the field? And again, these ideas of fever, tachypnea, hypoxia, these things that were supposed to be ironclad gold standard were really present in half or less of the patients. And so it became evident, and I think, again, now this is probably common knowledge, but at the time, really an important piece of information that helped us with our EMS providers in terms of how to protect ourselves, which was that acute febrile respiratory illness really didn't adequately define patients in the field in the EMS evaluation. So this led to our assessment of exposure, right? And so this is a relatively complicated figure, but I want to orient you. So along the x-axis is calendar days, and then those blue bars are how many encounters they had with COVID patients. So the light bars are the total number, and then the dark blue part of that bar is the number of actual exposures. So there's an encounter where you take care of a patient, and an exposure is where you didn't have adequate PPE. And we use the definition from the CDC. And again, early on, you can see there's a lot of dark blue bar filling up that total bar. And so we had a number of exposures. We had to move pretty quickly based on, again, what we had learned to understand how to protect our healthcare workers here in Seattle and King County. So we obviously expanded how we did this. So first was to identify in our region, and I think in many, this idea that skilled nursing facilities and long-term care were a high-risk location. We expanded to include not febrile respiratory illness, but any respiratory symptoms, in any fever or flu-like illness. We incorporated our 911 dispatch, and then we used this thing called the Scout model, where instead of sending the whole crew in PPE, we would send in the less severe cases, the minor cases, we would send in just one provider in their PPE, who would screen the patient and decide if everyone else needed to don their PPE or not. All with the hopes of keeping our healthcare workers unexposed, safe, as well as trying to conserve PPE. So we did some EMS wellness screens. I think this is pretty standard now, but something that, again, in the moment was relatively novel, where we screen everybody as they arrive to work and send them home if they have signs or symptoms of illness. That led to the need for testing, right? And again, now testing is more and more available, but in the early days of March, really not available. And so credit to the Seattle Fire Department for developing first responder testing sites that really opened up access for our public safety persons. We created a dashboard. As Dr. Dunn says, having this data available is really important, and to the extent it can be live time, it really helps inform decisions from day to day. We had over 24 public safety organizations from around the region access this resource for testing, in which we get the results back somewhere between 6 and 12 hours. All right, system monitoring, just to say, again, reiterate how important information and data is. Our public health department really has done a nice job of creating real-time dashboards where they're dynamic. You can go in and query those dashboards, and we've done, to some extent, the same thing for EMS. So that's, I think, a high overview of COVID and how we've responded and tried to manage with regards to general care and EMS. I'm going to turn it over to Michael now to talk about resuscitation specifically.
Thanks, Tom. Can you hear okay?
Yeah, I can hear you fine.
Do you want me to just share the slides from here on forward?
Sure.
That'd be easier for you. You have to, I will just steal it from you.
I'll
and
stop.
Take it over here. So hopefully that's working.
Yeah, I can see it.
Perfect. So this being a webinar about cardiac arrest, first of all, I want to thank Dr. Ray for taking the time to make these slides. I spent most of yesterday doing other tasks, and some of it related to testing, which has proven to be a big part of our job as EMS providers in the Seattle King County area now. So we focused early on the impact on cardiac arrest resuscitation for a couple of reasons. One of these was, let's make this drive, that as others noted across the country, there was changes in how the public reacted to orders to stay home, to stay safe, and their own fears around potentially catching COVID. And this chart shows a comparison of cases that were suspected STEMI by month from January 1 of 2020 compared to 2019 and 2018 for Seattle and King County combined. And we picked this disease because EMS is key to this, makes the diagnosis of STEMI, so it's pretty clean data, and is easily accessible through the electronic health record. And I think the data shows clearly that there's a really interesting decline in the number of patients who had an EMS diagnosed STEMI. It's essentially been cut in by roughly 40%. So it's only 60% of normal through just a few days ago. And the trend line doesn't really seem to be changing very much. So I wonder what's happened to these patients, as did the rest of our team. It feels unlikely that COVID disease protects people from having STEMI. This is a disease you've developed over many decades, and not perhaps the trigger of why you have one today maybe is something acute, but most of the time seems to be relatively spontaneous. So we would expect that STEMI prevalence would remain constant. So what's happening to these other 100 people? And are they basically dying at home? Perhaps not all of them are, but likely some of them are dying at home. And that was a concern of ours. So we looked at that, and this data is a little less obvious, but this is EMS incidents in which when the EMS provider got to the patient, they realized that the patient was essentially dead on arrival. There was no effort of resuscitation made. And that number is running a little bit higher than normal across the county. But perhaps it's hard to say for sure whether or not that's statistically different, but it's certainly not trending in the right direction. It makes us also worry that possibly some of the patients are dying at home from fear, or are they dying at home because they had COVID disease? So that led to an effort to then focus on the treated cardiac arrest cases. And this too seems to be roughly in line, maybe a little bit higher than the other years, but approximately the same. I don't think this is statistically different, and we're going to continue to keep an eye on that. So again, we worried what was happening. Meanwhile, as Dr. Newmar alluded to at the beginning of the webinar, groups of experts from around the world were trying to think through how should hospital personnel and EMS personnel respond when there was a potential for a patient having COVID disease. And they focused on the whole chain of survival. But for our point of view as EMS, we wanted to really focus on the bystander. And we know that bystander CPR improves the likelihood of survival. And we further know that the delay is critical. And even 1 minute of delay really makes a big difference. And therefore, telephone CPR is key. This guidance from the American Heart Association suggested that telecommunicators should screen for COVID-19 symptoms or infection or recent COVID contact. And then furthermore, they recommended that face masks or some other cloth should be placed on the patient and the rescuer, as Marcus Hong showed during his presentation. And while all these recommendations felt well-meaning to us, we were pretty concerned about the delays that these recommendations would induce in the response by the bystander, or that when the bystander's awareness was peaked about the potential for COVID, they would then refuse to interact at all. So that really worried us. And we wondered really what was the risk of the intervention of straightforward hands-only CPR by citizens, by bystanders, and using an AED. So we have a pretty good clue what the benefits of this interaction are. And just chest compressions alone have a number needed to treat to save one life of around 30 or so. But in order to really calculate and all those benefits accrue to the patient, and maybe sometimes the benefits accrue to the rescuer if they're related to the patient, but mostly the benefits accrue to the patient of this intervention. The risks, on the other hand, are mostly borne by the rescuer. So there's an imbalance here. And those risks are going to be dependent on the prevalence of COVID-19 disease among all the patients who have out-of-hospital cardiac arrest, and the risk that you would catch COVID-19 from just doing chest compressions. And then furthermore, what's the risk if you do get the disease that you're actually going to die from it? So I think we know something about the risk of death. The best evidence around this suggests that among those who get infected, the risk is in the neighborhood of 1%, somewhere between 0.5 and 1.5%. It's possibly as high as 2% among the symptomatic cohort. So it's a little, it's in that range. So we kind of have that one, I think, understood at this point. And our work was really focusing on this prevalence. So this is a bit of a busy chart, but we looked at, in a relatively rigorous way, all of our cardiac arrest cases that were EMS treated in the top half of the chart, and then dead on EMS arrival in the bottom half. And as the first COVID death occurred around the end of February, we divided the cohort into sort of a pre and post group. In the cohort after February 26th, so ultimately, as Tom pointed out, we became aware of the first case on February 28th, but later on learned that there were other patients who had died. And the first known death at this point in our county was around February 26th. So clearly there were cases of COVID disease that happened after February 26th among the out-of-hospital cardiac arrest cohort, but these were largely occurred in homes. Those are the red dots on the chart. And a few of them occurred in nursing homes. So they were in homes or they were in nursing homes. Importantly, we did not observe any cardiac arrests in public places that were subsequently shown to have COVID disease. Now, we recognize that not everybody got tested. The red dots represent people who got tested and had a positive PCR. So we also matched death certificate data and looked at the diagnoses and the death certificates. And we read the electronic health record narratives to try to identify patients who might have had COVID or what we called COVID-like illness or CLI. And those were yellow dots. And you could see they were scattered around. There were cases. But again, we did not identify any of these in members, people who died in public places. Now, we didn't have a large number of those calls. So it's likely that one of those cases will occur at some point. But we felt this was pretty reassuring and allowed us to fill in the rest of this chart. So the prevalence of COVID-19 among the out-of-hospital cardiac arrest cases in our community, we did not have the outbreak that Detroit had, but our community is probably more like most American communities right now. And the prevalence of COVID-19 is quite low, definitely less than 10% among the out-of-hospital cardiac arrest cohorts at the time of the peak in our community. It's still unknown what the risk of transmission is from chest compression only CPR, but the available evidence suggests that it's less than 10%. And some of that evidence comes from work done in Singapore and other places that show that simple surgical masks work, but patients don't have those on, and nor do rescuers. So if we look at others who had exposures, and there's work looking at household contacts and how likely are they to get disease. And importantly, there was a case series from a hospital in California that looked at one of the early patients that got admitted there for several days where COVID disease was not recognized. And the risk of transmission to that group of healthcare workers who took no precautions at all, including probably no face masks, was less than 5%. And chest compressions only probably don't produce very much aerosol, if any. So we feel pretty confident that that risk is less than 10%. And if you do all this math, you end up with a calculation that you have approximately 1 death in a rescuer from COVID disease for every about 300 lives saved from bystander CPR. And to us, that really suggests that you shouldn't change your telecommunicator questions and directions. You should stick with the current recommendations to ask, is the patient conscious or alert? And that is a no. And is the patient breathing normally? Then no. And then just giving simple instructions that we need to start CPR. I'm going to tell you what to do. And maybe later in the call, asking questions about what happened could be reasonable. So we've gone over what happened in the first few days of our response, how our system responded, how wearing PPE really works and protects people from getting the disease. and that we can be pretty confident in recommending to the public that they should go ahead and resume all of their normal resuscitation practices outside of a hospital during the pandemic. So I want to stop there, and Tom and I are happy to take any questions.
Thanks so much, Dr. Sayre. What a great presentation. Really interesting stuff looking at bystander and their risk patterns, knowing that early on, that might have been a barrier to people, doing CPR as an infectious risk. And we kind of, over the years, have kind of taught them that really wasn't that much a risk. And now maybe we have to reteach them again that issue now with COVID's on us. So there are a couple questions. Let me see if I can pop up the chat here. I lost my chat. Dr. Newmar, I think, had a question in the chat. I'm having a hard time pulling it up on my screen.
So he asked about, he asked Tom, so we'll let Tom handle this, about what do we mean by adequate PPE?
Yeah, so it's a great question, Bob. And so we do consider, we want our EMS providers, when they contact a patient with COVID, to have their N95, to don their N95. So that's generally what we have considered adequate exposure, in part because it's hard to know the course of any given patient, right? And so you start off with patient seemingly stable and then become unstable. And so leading to intervention and potentially aerosolizing procedures. So in general, when they engage with a patient who's COVID positive, we want to see them wearing that full profile of PPE to include an N95 mask.
Some of that, though, I'd say is due to our regional availability. So we had pretty large stockpiles of N95s, and we had very few surgical masks. And so that kind of made this decision easy for us. We do put surgical masks on the patients if they'll wear it. And in the hospitals, most of us are not wearing N95 masks. We wear regular surgical masks and only wear N95s if we're doing an aerosol generating procedure. But that's because we already have EMS telling us a bit about the patient, so we have a pretty good idea what is going to happen.
Great. There's another question. So in Seattle, did testing include antibody testing as well as PCR?
Oh, I'll defer to Dr. Sayre on that one. It's a good question, and it could go on for hours, but I'm sure Dr. Sayre can summarize.
Yeah, we've really gotten into the weeds on testing. So the short answer is no, but a longer answer. So for our teams, we are testing people when they get symptomatic, and we've made it really easy for people to get tested when they're symptomatic. And our workforce is incentivized financially to get tested because if they do, then they have a pretty good chance of being able to claim workers' comp if something happens to them if they test positive. So we think we're capturing the vast majority of people who had the disease by doing PCR nasal swabs. And we do, as Tom pointed out, we had our own testing sites. And so we had good control over this, and we knew who got tested. Subsequently, we've engaged with a research group at the University of Washington and the Fred Hutchinson Cancer Research Center to look at immune response. And they were very interested in using the first responder workforce as study subjects because they felt like they would be amenable to it, and they knew where to find them, and they were having reasonably high number of contacts with people who had the disease. So we've had several hundred first responders go and get antibody testing and nasal swabs who had exposures but did not have symptomatic illness. And I don't know if Tom's got a more updated number than I do, but I think it's in the neighborhood of 2 or 3 that tested positive for antibodies. It's a very low number.
Great. And then Dr. Newmar kind of had an additional kind of ask that question. Would it be reasonable to start with surgical mask and transition to N95s if high risk for aerosol generating procedures were done?
So I'll start, and just my simple answer is yes. That would seem quite reasonable. As Michael says, in the hospital, we use surgical masks in those instances. So I think that is appropriate. Again, our use of N95s has been in part because of that's the supply we had. Michael, you have other comment?
No, I agree.
Terrific. And then one more question from the group. If there was is there an approved TCPR protocol that can be used for ACE accredited EMD centers to improve hands-on chest time?
Well, I would say I don't know about the details of accreditation, and so I think, but I keep it simple and ask those all-caller questions of, is the patient conscious and is the patient breathing normally? No and no, then let's just get the patient flat on their back, put your hands in the middle of the chest, and start pushing. I don't want to trivialize the details here, but that is essentially all we do in King County, and it has served us very, very well.
I think that in addition to having clear guidance, another key is to actually measure what's happening. So getting the recordings and providing feedback, getting a sense for what's actually occurring and how long is it taking is really essential. And you'll find, I'm sure, that there are 10, 20, 30% of cases where the diagnosis isn't made at all. So you don't give any telephone CPR instructions because you miss the call taker missed the diagnosis of cardiac arrest. Some of that's unavoidable, and some of that's maybe because the questions weren't asked in an ideal way.
I think that's it. Let me see if there's any other. I think we'll save the other questions for the final panel kind of discussion, and we'll kind of move on. I really appreciate Dr. Sayer and Dr. Ray presentation today. I'm going to go ahead and take back the screen. And what I want to do is introduce our final speaker. Our final speaker of the day is Dr. William Fales. Dr. Fales is Professor of Emergency Medicine and Division Chief of EMS and Disaster Medicine, excuse me, at Western Michigan University. He is also the Michigan Department of Health and Human Services Medical Director of State and EMS and Trauma. Dr. Fales will be talking about the impact of COVID-19 on state EMS protocols. Dr. Fales, you can go ahead and start sharing your screen.
Good morning, everyone. Great to be here. Thanks for the introduction. Thanks for the great talks, and it's been a really full morning of good content, and really appreciate everyone taking the time to participate today. So thanks again for the opportunity for me to be here. The impact of COVID-19 on state EMS protocols and is the name of the talk, and I think I'll probably end up doing a little bit more on the impact of the protocols on some of at least our basic preliminary information on out of hospital cardiac arrest management. And in terms of disclosures and conflicts, a few disclosures, but none should result in a conflict. And we talk about protocols. Dr. Dunn mentioned in his talk a number of our protocols that we've implemented in Michigan, typically as emergency protocols. And these really, the very first one was I think back on February 9th, and that was related to the Detroit Metro Airport quarantine station operation. And shortly after that time, we implemented our first dispatch guideline. And over the course of the pandemic, these have gone through multiple changes, as most people on this call probably are well aware. The current list of the emergency protocols are available at michigan.gov/EMS, and you can navigate to those protocols pretty easily. The protocols really kind of span from initial staffing and preparation. Some of those required an executive order to implement because it required a change in our public health code governing EMS. Others were more operational or clinical, including telehealth protocols for treat and paramedic initiated refusals, and destination and transport of patients to alternate care facilities. The main protocol I'm going to really try and focus on, and that's our cardiac arrest in a patient with suspected or confirmed COVID-19. This is really the principal protocol for cardiac arrest management. This protocol came out relatively early on. I think it was about the time we started to have our first case in Michigan, which was March 10th, our first 2 cases. And the protocol has it's gone through a few changes since the original protocol, but it has an inclusion criteria that are kind of based on some of those traditional CDC guidance that have evolved over time, focusing on the respiratory illness, fever, et cetera, and tried to be updated to the most current CDC guidelines, realizing that we're seeing increasing patients that don't read the playbook before they call EMS, or the caller calls EMS in the case of a cardiac arrest. We really did try to stress statewide to have a very low suspicion for COVID-19, and obviously in the heat of battle, when EMS encounters a patient in cardiac arrest, we have to begin resuscitation kind of concurrently as we're gathering that history, so we don't have that luxury of getting a full history in all cases. But this was at least the entry point for this protocol. The protocol included a reference to PPE, and just this was consistent with our more broad PPE protocol that was put out by the department, and really emphasizing N95s when available for the full resuscitation. And again, from a practical perspective, and I think Dr. Sayre hit this nicely, is really you have to approach every cardiac arrest as it would be a prospective or potential COVID patient, and just having a low threshold for that. And you can always dress down, but start by kind of almost universal precautions, the new universal precautions. The treatment part of the protocol, really, if the patient failed to have any of the identified pre-arrest symptoms or was not known to be COVID-19 positive, then EMS should proceed with their general cardiac arrest protocol using standard precautions and the same treatment algorithms that they normally would. For patients that were included in this protocol, we had a few things that were tactically different as it relates to the airway. We made a decision to discourage oral tracheal intubation. Many of our systems have gone to use of supraglottic airways in place of endotracheal intubation during non-COVID times. And we felt that this airway, type of airway, offered a high chance for first pass success rate and allowed kind of literally to have an arm's reach approach and keeping the operator further distant from the business end of the patient as it relates to being exposed. So the no intubation protocol was put in place. And Dr. Dunn, also in Michigan, our protocols, local medical control authorities have the ability to make revisions and execute their own emergency protocols as well. So some systems did opt for a contact medical control for approval to intubate. General guideline of to the best you can, try to keep the crowd a little further away from the patient than you might normally. Try to preserve that 6-foot distance as you are able. And that's obviously not always possible, but especially people that are not actively involved in resuscitation, try to keep them back a row or two. And probably one of the somewhat more controversial things was that the early termination of resuscitation protocol for these patients. After 10 minutes of failed resuscitation, then we should consider termination of resuscitation under medical control direction. What led to that protocol was, at least in part, was some information from Terry Shields and our Michigan Cares team with some information. We tried to couple that to some of our state EMS data, where we did keyword searches for fever and other things that might suggest pre-arrest respiratory illness. And what we found was an extremely low ROSC rate in those cases that we're able to match with outcome data, and obviously even lower survival with good neurologic outcome rate. So that kind of led to the decision to go with that 10-minute resuscitation period before considering termination. Also, that we didn't want to transport patients that remained in cardiac arrest. That's still somewhat variable around the state. Some systems don't transport patients with failed resuscitation, while others continue to transport after a certain amount of time and effort in resuscitation. So we felt that that was inappropriate for this patient population. And before moving the patient after obtaining ROSC, make darn sure you in fact had ROSC, at least a blood pressure above 60, and that was sustained for at least 5 minutes. And if we weren't able to obtain ROSC, then we really should pursue field termination. For witness cardiac arrest in the patient care compartment of the ambulance, pull the vehicle over to the side, open the doors, make sure everyone is in full PPE, work the resuscitation off the side of the road. Only if you have mechanical CPR should you be considering transporting in that situation with the patient in the patient care compartment. So that basically is the cardiac arrest protocol. In the few minutes we have left, I'd like to kind of walk through a little bit of our preliminary data. And at the risk of offending Terry Shields, who is kind of our queen of clean cardiac arrest data, this data is not clean. It's dirty data. It's not from CARES. It's pulled out of our statewide EMS information system and analyzed with an application called Biospatial, which is a pretty robust data analytical tool that we've had available in Michigan, both at the state and medical control level, as well as now available to agencies that we would certainly encourage people to use if they're not. The data analysis that we're going to look at is really, it's overlaid on the fact that, over the last several months, our EMS agencies around the state have experienced significant reductions in call volume overall, anywhere from 25 to more than 40% reduction in call volume. So with significant decline in call volume, we want to focus and look at a little bit of our cardiac arrest data. We're going to take a look at two sets of data in two different populations. We're going to look at all cardiac arrest where resuscitation was attempted, and then the kind of the cherry picking subset of a near Utstein group of cardiac arrest with presenting rhythm of VF that's felt to be of likely cardiac etiology. The current configuration for the biospatial application doesn't allow us to identify witnessed arrest very easily. So it really won't be a true Utstein comparison, but I think it'll give you some idea of that subset. And then we're also going to apply it to the population, first statewide, and then we'll look at kind of the hardest impacted areas of the eastern, southeastern portion of Michigan. So this is the first graph. The top is 2019 data. The bottom is 2020. And this is, we're looking at a 3-month period from March 1st to May 31st in both of those years. The very first columns or graph is a portion of a week. That wasn't intended to be it really isn't a slow cardiac arrest back in 2019 on March 1st. It only represents a couple days. But if you can see, looking at that top graph, on a typical day in Michigan, we're doing around 250 working arrests. And when we go to the bottom of 2020, during that same 3-month time period, we see a 43% increase in that, going above that orange bar of the 250 per week. Almost every week, we are well above that number. You can kind of see, and this fits with Dr. Dunn's slides, where that kind of peak was in the very early part of April. If we look at a little bit more information from Biospatial, and we're going to kind of go from left to right, looking first at bystander AED rates, then bystander CPR, and percent of bystander witnessed arrests. This fits in nicely with other information we've seen. we really have not seen a significant degradation statewide in the percent of bystander AED use or bystander CPR or the number of bystander witnessed arrests, looking at all of our arrests in this case between 2019 and 2020. What we do see is a fairly significant increase in the field termination rate, going from 47% in 2019 up to 59% for the 3 months of 2020. And kind of conversely, we see some compliance with the state protocol about sparing intubation, with a significant reduction from 31% down to 12% reduction in endotracheal intubation. Now, the far right is our ROSC rate, and this is where Terry can just put her fingers in her ears and close her eyes. This is a limitation of our state EMS data, and this is exactly why it's so important to have CARES data critically looked at by EMS agency and hospital personnel to really clean that data up. So this is not reflecting the unknowns. So when you add in the unknowns, that ROSC rate gets up to, you can add another 25 to 30% above that. So we have a very high percent of unknowns with this current analytical tool that we're using. And that's why we really need to kind of manually look at each one of those records and identify the true ROSC. So don't spend a lot of time on that. It does look like there's a decrease in ROSC, but again, it's very poor data. If we now go to that kind of cherry picking subset of the initial presenting rhythm that's shockable, either AED shockable or VFib or pulseless VTAC, we normally would have about 25 cases a week, and this is of cardiac origin, not necessarily bystander witness, but most of these end up being bystander witnessed. So around 25 per week, and what we see is an increase in the total number of those cardiac arrests by almost 15% over the last 3 months. Now that said, when we look at a 43% overall increase in total arrests, 14.8% increase in the VFib arrests, what it reflects is that the large number of increase in arrests are from non-shockable rhythms, and that wouldn't be particularly surviving if we're going to attribute COVID as the culprit, with or at least a major contributing culprit to the increased numbers. But nonetheless, there was an increase in absolute numbers of VF arrests. And from talking to hospital colleagues, it doesn't sound like there's been a lot of information from hospitalized patients that were critical where they would experience abrupt VF arrhythmias. So this could reflect other non-COVID related causes of cardiac arrest, whether ischemic or primary dysrhythmias. The same little graph that we looked at before now, again, kind of follows those numbers. Bystander AED use seems similar. Bystander CPR rate for this subset of over 50% looks good without really any change, actually slightly up from 2019. And the bystander witnessed arrests continue to be at a high number at 71%. Similarly, we see an increase in field terminations and also a decrease in field intubations. The overall ROSC rate certainly looks better than what we saw before, but again, it's still very much limited by incomplete and inaccurate data, so can't put a lot into that. One thing I really did want to take a moment to look at, and that's statewide cardiac arrest data by race. And on the left is 2019 data, and on the right is 2020. In the kind of 11 o'clock position, you'll see 12 to 13% of kind of that orange color that is unknown. But nonetheless, what really is striking at about 9 o'clock in the donut is the increase in 2020 among Black subpopulation of cardiac arrest patients, going from 18% up to 26%. And that certainly follows along with our data on death rates among Black patients. And unfortunately, this appears to be maybe another example where Black lives matter in a completely different context. And the factors that lead into that, are many and will need to be worked on for some time to try and resolve. Just to end with here, just to focus on the kind of the 5 counties in Michigan that were most severely impacted. Like many states, we had a very asymmetric outbreak with a heavy focus in Southeast Michigan, particularly in metropolitan Detroit. The rest of the state really saw a lot of sporadic activity, but not extreme activity at all. In the Metro Detroit area, at peak, we had over 4,400 hospitalized COVID-19 patients. We had 12 days with over 1,000 COVID-19 patients on ventilators. I think our peak was 1,223 on one particular day, 176 patients put on ventilators in one day. Records we hope we never will ever try to break again. When we look at the high impact counties, Wayne County houses the city of Detroit, and this death rate is 107 per 100,000. This is the most current data I could get from our Bureau of Epidemiology. And this Wayne County data excludes the city of Detroit. That data is reported separately, but you can see the city of Detroit death rate of 224 per 100,000, is just far above our state data average. It really exceeds the city of New York with their death rate when we look at time from initial cases to the number of deaths per 100,000. Other counties are Oakland and Macomb and Genesee County in Southeast Michigan, and going up as far as the Saginaw County. And so any county that had a death rate that was above the state average, we look at as a high impact county. So where we had an overall increase of 43% of total cardiac arrests in these 5 counties, which represent almost half of our state population, we saw a 61% increase from typically about 120 cardiac arrests per week to well over that during the last 3 months. Looking at the same attributes we looked at previously, bystander CPR, bystander AED use, and percent witnessed, all pretty much similar from one year to the next. And the same thing with our increase in field termination, and about a significant reduction down to a third of what we had before in terms of endotracheal use, with the same limitations with ROSC that I mentioned before. And then that subset of initial rhythm being shockable in a presumed cardiac origin patient may or may not be bystander witnessed. We go from about 15 per week. We see about a 21% absolute increase in these 5 counties of bystander witnessed cardiac origin VFib cases. So a bit higher than what we saw statewide, but again, with that 60-some% overall increase in resuscitations, most of our resuscitations were not in shockable rhythm patients, but we did still see an increase in the absolute numbers. This is the one area where we did see a decrease, and I think this was mentioned one of our other by one of our other presenters. The bystander AED access dropped from 15% down to 9%. Not real surprising considering the kind of the lockdown and the decreased access to public venues. Bystander CPR looks similar, but I also like that notion that the bystander CPR rate in public venues dropped while the bystander CPR in the home may have increased, resulting in no real difference. And similar things that we've seen in all the other groups in terms of termination in the field and decrease in intubation rates. So with that, during this 3-month period, we saw a significant increase in cardiac arrest statewide, and even greater increase in the 5 badly impacted communities or counties. We saw fairly similar bystander CPR rates, AED use rates, and bystander witnessed cardiac arrest rates, with the exception of the bystander AED use in shockable rhythms was lower than what we saw the previous year. The arrest with shockable rhythms of cardiac etiology increased, but less so than the non-shockable rhythms did. But nonetheless, something was causing an absolute number of increase in VFib arrests, at least it appears so. Intubations decreased while field terminations increased statewide in our high impact areas. And unfortunately, the ROS data is still not where we need it. That's why we need to be doing cares. So, this is kind of I think in many ways, kind of a kind of a thing. During a pandemic, more people die. We understand that. The question really, and I think Dr. Newmar kind of got into this a little bit, what's the cause of the deaths? And I'm sure it's multifactorial and probably has wide variations between areas of Southeast Michigan where COVID-19 was much more prevalent and the rest of the state of Michigan where it was much more sporadic. But it makes us wonder, are we missing acute MIs? Our preliminary information doesn't appear that we have less STEMIs than we had the previous year, unlike Dr. Sarah reported, but we're just starting to look at that data. Other causes of cardiac arrest that were not COVID related. And then Dr. Dunn kind of mentioned about, the EMS system contributing or being peripherally involved with some of these cardiac arrests, EMS making an encounter, not transporting, and then being called back for a cardiac arrest or a dead on scene some number of days later. And we've seen that kind of throughout the state on a number of occasions. So something that needs further investigation for sure. And we need to do a better job at crisis communication with the public about, even though we're in the middle of a pandemic, when should you have that syncopal episode looked at, or the chest pain you've been putting off as you've been on your new treadmill because you're sheltering in place. So thank you very much. And I appreciate again the opportunity to speak.
Well, thanks, Dr. Fales. Again, another great presentation. Although the data you say aren't clean, I think it really gives us a glimpse into the variations that COVID may bring, and those questions that we need to bring up. I think will really kind of funnel right into our panel discussion. There are some questions for you, so I'll have you keep your sharing of your screen so we can kind of go through these with you. But one question is, when is it appropriate to treat all out-of-hospital cardiac arrest patients as COVID-19 potentials, and when is it not? Will we ever go back to not using PPE for aerosol-generated procedures while treating cardiac arrest patients?
Yeah, I would say I think in the time we're in, this is probably going to be a game changer, and for maybe a few people on the call that have the years in EMS might recall a time many years ago where gloves were not standard issue on ambulances except inside an OB kit. And what changed that was HIV and the AIDS epidemic. So I think that we will probably be seeing, and probably should be seeing, a change for the long term in PPE. And I think, as our colleagues in Seattle said, is the initial approach to every arrest, I think, really needs to be, certainly while we're in the midst of the pandemic, that this is going to be COVID-19. God willing, at some point, if we have a vaccine and we in the herd develop significant immunity, that may change. But I think the idea of having, taking respiratory precautions, and what right now it's COVID-19, but for years in the past, it could be a bad flu season that we could have had some mitigation of those risks. So I think the benefits of more liberal use of PPE are real, and they're probably worth keeping for the long term.
Terrific. Another question is, how do you see the PPE situation for the EMS system evolving over the next 3 to 6 months? I think that's specifically for here in Michigan.
Yeah, we are starting to see both at the hospital and in the EMS restoration of the supply chain, as all of us that bought into the idea of just-in-time supply are definitely rethinking that. And just like we try to take advice from Seattle with good resuscitation techniques, we probably should have paid attention to their logistics and use of N95 caches. So with the return of a normal or a better supply chain, I think we're going to start to see more wide availability of that at the regional level, where we are now starting to cache more abundant PPE of all types for the potential for the second surge that you heard about earlier, that we hope won't come to any great degree. So we're better. We're still not where we need to be, but I don't think we're going to be seeing the severe shortages like we saw before.
Thanks. And there's one more question before we go to the panel discussion. Can we justify continuing 10-minute termination under current conditions in Michigan?
So remember that the 10-minute termination was principally intended for patients that were suspected to be COVID-19. That 40-year-old that gets on the treadmill and has a VF arrest. I mean, those are full court press type patients, and we really didn't want to limit them to a 10-minute resuscitation. These were more for the septic or pre-arrest symptomatic patients. So we would still, I think, want that to continue as well. And if we have patients that present with a high degree of futility, septic shock patients that arrest, whether they're from COVID or anything else, I think those become more appropriate for premature termination.
Great. We can actually get more into these questions maybe in our panel discussion, so we can kind of continue this. So I want to end Dr. Fail's presentation there right now. And prior to beginning the panel discussion, I would like to launch a final poll question for our audience today. So please take a moment to answer this poll. I can pull it up. It is coming. Okay. What has been your organization's biggest challenge since COVID-19? Okay, we'll give it another 20 seconds here and we'll kind of close this one out. All right, we'll go ahead and end the poll. So most people talked about communication, training, and coordination and adequate PPE. So I'll share those results. And now what I want to do is open up our final discussion panel for the day. I'll first ask all the presenters to open up their audio and video so we can all be seen and heard. So once we get everyone up and running, we'll kind of start the session. Okay. So Dr. Sayer, did Dr. Ray prevent him from opening up his video?
I think I'm on, Jim.
Okay, perfect. And then Michael's not going to join, or is he had to leave?
I'm here. I'm not able to start the video. You have to unblock it.
Oh, let me see here. Maybe I did that. Does
There
that
we
help you
go.
a little bit? Okay. So how this will work, I'll ask each of our speakers to give their top key points and potential next steps for moving us toward improving out-of-hospital cardiac arrest in the COVID era. This is being recorded, so we'll be able to go back and kind of really identify, where are these key issues that we need to kind of really address to kind of move the needle in survival. And then following all their brief statements, we'll open it up for some final Q&A using the QA board like we have done previously throughout the entire webinar. So for sake of better methods, what I'll do is I'll just ask the presenter who is kind of first on my list here as my screen kind of displays in the gallery view. So how about Dr. Fails? Why don't you give us your final thoughts?
Yeah, I think that really looking at what's the new world order in a post-COVID EMS system and trying to strike some balance between workforce protection and not losing ground on the tremendous gains we've had in Michigan and around the country in out-of-hospital cardiac arrest. So how we do that remains to be seen, but what should that protocol look like? The question about what PPE should we be doing, should we be using, and just trying to find that sweet spot. I love Dr. Sayre's explanation about bystander risk, and I think going to the issue of education, make sure we have a well-informed workforce that understands that this is worthy of good attention, but at the same time, we still have patients that are vulnerable that can be resuscitated with a good aggressive EMS system.
Terrific. So we'll go ahead to the next person on my screen is Dr. Ray.
Oh, great. So I concur with Dr. Fales. I think importantly, we've had to react and make some decisions using sort of our best clinical gestalt. I think it'll be critical now, as Dr. Dunn says, is to try to refine and inform based on evidence, and that often means data. So I think as we go forward and try to inform best practices, it'll be really important to critically look at using data at the different links in the chain to try to find that sweet spot, as Dr. Fales has said. I'll stop there, Jim.
Terrific, thank you. And then the next in line will be Dr. Dunn.
So I think that one of the things, and Bill, I think, kind of touched on this a little bit at the end of his talk, is for us to take infectious disease and infection control seriously. It's funny because a lot of my colleagues in the emergency department weren't much for wearing a face shield or anything when they were intubating before this. And they always kind of made fun of me because I always did it, but I wasn't doing it because so much of worried about infection control. I had just experienced the puke in the face as a young provider, and it kind of made me like, oh, I should wear PPE. But if we think about it, we should be wearing PPE a lot more than we do, particularly during just the typical respiratory illness season. How many of our colleagues have gotten sick, with influenza despite their vaccine, who never think about using PPE? So I think just refocusing on infectious disease and infection control, especially as we move into the challenging multi-drug resistant bacterial infections and whatever next viral threat is out there along with the ongoing coronavirus threat. So I think it's something that this is unfortunately a harsh reminder, but that, we've always been living in a world of tough infectious disease challenges, but weren't taking them very seriously.
Great, thanks for that. And then Dr. Sayre?
Yeah, I think the main message for me is just to remind folks that we're talking a lot about PPE because it actually works. So if you wear your PPE and you wear that, and by that I mean you have eye protection, a mask, a gown, and gloves. And we can debate a little bit about which mask for different circumstances, but that basic getup of MEG, mask, eye, gown, gloves works really well to protect you from people who have infectious respiratory-borne and blood-borne contagious diseases.
And finally, Dr. Newmar.
Yeah, I think for me, there are two take-home points. One, I actually am surprised by the data about bystander CPR rates. I fully anticipated and feared a dramatic drop in bystander CPR during this pandemic. And it may be, probably is reflective of the fact that the majority of arrests are at home and a lower proportion are in the public. But I don't think we should ignore that decrease in bystander CPR rate in the public, because again, that's a great source of our number of survivors. And I think we saw today two, what I would maybe even consider two extremes of how to deal with that. You saw from Singapore the development of these bystander kits that include face masks for the provider and for the patient, to the opposite extreme in Seattle, where they're not really changing anything they're doing in terms of the bystander response. And I don't know what the right answer is, but I do suspect as we continue moving forward, we ought to be prepared and have a strategy to address the potential sustained decrease in bystander CPR in the public setting, and how we ought to address that, because and it might even require a messaging strategy to the public through our traditional pathways of AHA or other, the Heart Rescue Program and the Resuscitation Academy. But how do we message the public about, and how do we, assure that they're safe in terms of providing bystander CPR in a public setting where it's someone you don't know? But I think that's going to be really important moving forward. And then the other one I think is I think we're going to just have new universal PPE for treatment of cardiac arrest that basically protects against aerosol-generated, viral pathogens. And similar to what Bill said about how things changed with HIV, I think that, in terms of safety of our providers, it keeps it simple, and, just every cardiac arrest treated as if it's a, COVID or COVID-like illness in the future might be what we're looking at.
So, Jim, can I comment on Bob's priorities? It's Tom Ray.
Yes, these are great. This is exactly what we want. If you want to chime in.
So I think Dr. Newmar is spot on about the bystanders and the general public, right? That the interventions that occur earliest after collapse are the ones that have the most influence on the trajectory of that patient. Hence, bystanders are more important than EMS. EMS is more important than hospitals, on down the line. So I really think we need to focus on bystander care here. So I would just be cautious about interpreting the early data. I mean, some of it is that it's early, and some of these things, the impacts trickle down into the community more slowly. And so we may see over the next several months or even years that this has an impact on the likelihood. And then the other thing is to understand that it may not qualitatively change a yes/no in terms of starting bystander CPR, but it may actually delay by minutes. And so even our current data capture may not be sufficient to really understand the impact if we're trying to understand the time to the onset of bystander CPR. So I think there's some work to do to really dig in here and make sure we don't lose all the gains we've made.
Yeah, thanks for that comment. Anybody else want to comment on any other panelists' kind of key points before we ask some questions from the audience? Great. So kind of along those lines, there's a question about, do you think it's feasible to have some type of PPE kit attached to all public AEDs kind of moving forward? Would that be a reasonable kind of approach?
Yeah, I would comment on that, and I think that alludes to my point of, what Marcus showed was sort of like that kind of PPE kit. So, the question is, how much training does it require to do that properly, and how much does that delay initiating CPR relative to the benefit or necessary need for that protection? And I don't know the answer to it, but I think it's going to be a challenge, because what Tom said is that, yeah, we could sort of have either, dispatchers or have these kits with the AEDs providing this higher level of PPE, but it's guaranteed to delay the onset of chest compressions. And then, what is the risk benefit of that in the public setting? And it obviously depends on the incidence of infection in the community, right? If you have a 1% prevalence in the community versus a 20% prevalence in the community, that risk benefit changes.
We also have to find bigger boxes to make room for the tourniquets and the Narcan and everything else that now goes into these than just the old AED.
So I'm just going to react.
Although I was going to say that a lot of us have at least some bleeding control stuff that we've been deploying. So, the idea of, at least some gloves and things like that.
I've lost my audio. Can people hear me? Can you put your thumbs up if you can hear me? Okay. So I'm going to try to do this with no audio real quick. So these things only last apparently 3 hours. So just let everyone know. So there was a question from Dr. Brian O'Neill to the Seattle contingent. what was the process criteria you used to designate your cardiac arrest patients as either PUIs or COVID patients?
Is the context for that question overall or for our study? So I'll assume it's for the study. So the COVID patients, we capture the test results. So we are part of the health department, and we have the full data feed from the state health department in terms of all the people who tested positive. So we have daily workflow, as Tom alluded to, where matching is done by name, and that does a quite good job. And if the name's misspelled, so we may miss a few, but we capture the vast majority of the cases that way. And then the other was to basically read the record and see if the story sounded like they could have had a febrile / respiratory type illness, recognizing that that wasn't necessarily perfect. And we did this in a blinded way where we read about 100 records that had test results. Some were positive and some were negative. And this methodology worked pretty well to identify a cohort of patients who were at higher risk. So the ones that we classified as COVID-like illness who were tested in this validation group, half of the tests were positive and half were negative. So we were sensitive in terms of picking up the cases, and the ones that we classified as not likely to have COVID, only a low proportion of those people tested positive.
All right, so I think the next question is going to be, let me see, from, again, to the Seattle King County kind of contingent. Can you clarify in Seattle King County using CDC standard PPE on codes, i.e. splash gowns, N95s, etc., we have found downing this level really slows us down. What is your experience, and do you follow those protocols?
I'll let Tom answer that.
So yes, this is what we do. They get the word from dispatch whether there's, suspicion of cardiac arrest or CPR ongoing, and they're instructed to do their very best to don their PPE en route when they have any information ahead of time, and to wear that PPE from the onset of that call all the way through. So I will say that we are keenly interested in understanding whether there are delays and where those delays occur and how they might affect care. I don't know that we have a great granular view in an objective, systematic way that would call out specific delays at this stage. Again, it's an important point. I don't know, Michael, do you have other comments on this?
Well, I think, that life's about trade-offs. So the good news is there's no traffic. Some of the drive times have gotten a little bit shorter. So I don't know what the net result is of all that. Sometimes the crew can at least don part of the PPE while they're driving. So I'm not clear how much the delay actually is impactful for our teams. More to come on that for sure.
All right, so the next question is really, we spend a lot of time teaching hands-only CPR in public settings to encourage those fearful of helping. How will this be received now that we have COVID?
I think we're in better shape than we were when we were not teaching hands only, for sure. And again, the question that's unknown really is, does pushing on someone's chest create enough exhaled air and particles that puts the provider at risk? I think if there is, exhaled virus, what is that risk of transmission? Now it's, the amount of breath is going to be less. However, typically when you're doing hands-only CPR, your face is right over the patient's face, and and we don't know whether doing covering the patient's face is valuable or necessary. So I think what we really do need is some research to really figure out what that true risk of transmission is in hands-only CPR, with and without defibrillation, to really be able to inform the public of what risk they're undertaking. If you look at Mike's calculation, he puts an estimate of 10%. That may be right. It may be much lower. It may be higher. We don't really know. But I think if we could figure out how to study that and figure that out, that would be, I think, very helpful.
With Michael's work with in your database in Seattle, in King County, is there an ability to go back? You can identify patients that had bystander CPR on COVID positive patients. Is there a way to go back and try and get some sense of any of those that became positive?
Yes and no. So before we had electronic health records, we had paper charts. These were kind of neat things. You wrote on them with a pen, and they had a field to record the name and the phone number of the bystander. And the NEMSIS data set does not have such a field, so we no longer capture who the bystanders were. So we don't really know.
So what I want to do is just ask one final question of the panel before we kind of end. I think we all talk about getting this message out and good public communication. What are the methods to communicate with the public and through the public, obviously through legislators and governments, to get this message out there? We do a lot in our inner workings and our inner circles with conferences like this or resuscitation academies and things like that. But how do we get that message out? What's the venue for getting that message out to the public so it matters?
Well, I think one of the things we can do that we've been trying to do some more of in our area is to get as many public officials like on message, or doing even doing a demo where we have them and we do a quick 30 seconds of them doing some hands-only CPR on a simulator or something like that. I think in addition, anything that we can do that promotes businesses, whether it's local ordinances and things, or incentives to make sure that they're doing that kind of community responder training, not just hands-only CPR, but other things I think that we should be training community responders to do. So any kind of incentives that we can provide to do that, or even ordinance support, I think is a huge step forward.
Yeah, I mean, I would say that we do need to build in, the changes that this pandemic has created into all of our CPR training, right? So we certainly can't ignore it. So any ongoing CPR training courses, bystander courses, need to have it acknowledge, the presence of this, the COVID pandemic and other risk of infection, and deal with it head on. In order to be able to, still encourage people to respond. But I think the challenge is that we don't have a good handle on the risk that people might be exposed to. I think we just need more information for that.
Well, thanks so much, everyone, for answering that question. I think it's a real important issue on how we kind of get this message out. I think we need to end the webinar here. I really appreciate all the speakers coming to present. I think this has been a really terrific discussion. COVID-19 definitely presents a new paradigm in our management of out-of-hospital cardiac arrest. And I hope everyone has gained some insight from the experience of our speakers. I think as there's been several mentions that public health is really the centerpiece for this. Keep that in mind going forward. And before we end the call, I really want to send some thank yous to the Save My Heart Planning Committee. Without this group of volunteers, could not have put this on. And I think I really appreciate all their help and dedication. And also the speakers, Drs. Dunn, Bales, Newmar, Owen, not one, sorry, that's my typo, Drs. Ray and Sayer. And then also wanted to thank everyone for attending the webinar. As attendees, together we can continue to make progress towards increasing survival of out-of-hospital cardiac arrest. Thank you so much. Be safe, and please complete the survey that should be following this webinar. Have a great weekend, everyone.
Thanks, everybody.
Take care. Thanks, everyone.
Yeah, terrific. Thanks.
Thank you.
You.
Thanks, Seattle. Take care.
Thanks everyone for joining.